Тоже свой окружающий мир для жизни рода человечества, чтобы было добрым, вот богатый, говорит, за что ты богат, что ты ценишь? Для того, чтобы ты пользовался, а для того, чтобы окружающие тебя люди, пространство было богатым, достойным для жизни своих соотечественников. Вот это я понимаю добро настоящее, а не для себя. Счастье человека, когда сделаешь добро людям. Вот это мой девиз.
Он до сих пор крепок, как камни, из которых сложены вершины Улутау. Кажется, возраст для него всего лишь цифры, и ни года, ни постоянный ежедневный труд не способны сломить его волю к жизни, стремлению к победам и поиску нового, важного и драгоценного для здоровья нации.
Я, например, вторгался туда, куда мне говорили, нечего делать, там ничего не добьешься. Я шел и добивался. Через потери, изгоем был из-за того своей верности. Знаете чего? Своей нации. Меня обвиняли в национализме. Потом обнаружил, что это такое. Оказывается, нацизм есть. Моя нация, я любовь моей нации, я ничем не поменяю. Моя нация казах, я казах. Как я могу другую нацию любить, когда я не могу? Поэтому, когда меня обвиняли националистом, я гордился. Да, я националист. Что интересно, Кунаев был в этом отношении защитником. Я активненько работал, хотел уходить. Тогда секретарь обкома говорил, в чем? Да, он хороший специалист, но он махровый националист. Знаете, Кунаев сказал, вот как раз такой человек и нужен. Он спасал меня.
О его жизни и подвигах написаны сотни книг, сняты десятки документальных фильмов. Его имя уже навсегда вписано золотыми нитями в истории страны и мира. Путь Турегильды Шарманова шел через сложные времена. Война, послевоенные годы, великие стройки и расцвет городов, мечты и надежды миллионов на счастье, тяжелое постсоветское восстановление и борьба за здоровье нации. В потоке испытаний и закалился его характер. Человек-эпоха казахстанской медицины. Человек, смыслом жизни которого стала забота о здоровье наследников великих номадов. Почти 40 лет назад ему удалось сделать практически невозможное.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
1978 год, сентябрь. Тяжелое время холодной войны, когда Запад с опасением смотрит в сторону Советского Союза. В Алма-Ате созывается Всемирная конференция. Турегильды Шарманову удается уговорить глав делегаций разных стран приехать в столицу КазССР. Гостеприимство казахов привело высоких гостей в дом Шарманова, где и была подписана знаменитая хартия. Позже об этом событии будут говорить. Документ, рожденный в квартире профессора Шарманова. Тогда о нем узнал весь мир.
The Leon Bernard Foundation Prize to Professor Т.Ш. Шарманов of Kazakhstan.
За эти заслуги спустя годы Турегильды Шарманов был удостоен высшей награды Всемирной организации здравоохранения – медали Леона Бернара, которой за всю историю в мире награждались лишь 42 деятеля здравоохранения.
I am infinitely proud and delighted that the triumphant victory of the 19...
А начиналось все с огромной мечты мальчишки, который после гибели любимой сестренки пообещал себе посвятить жизнь помощи людям.
А я мог умереть от столбняка. Тогда думал, вот незнанию много умирает людей. Вокруг умирает всем. Моя сестренка умерла. Вот того, что, например, осталось на улице со мной. Я любил свою сестренку, мы на улице любили спать, например. Там окошки нет. У нас такой, знаете, если можно с точки зрения здравоохранения, грамотности, закрыты окна всех, где я живу. Там нет форточки. Вот в этом затклом окружении приходилось жить, и умирают многие люди. От того, что неправильно, неграмотно свою ограждает, оберегает свою жизнь в таком помещении, очень опасном помещении. Там туберкулезные палочки, все может сохраниться. Почему в теле много умирает людей? Потом моя жена заболела туберкулезом. Потом смотрю, не только моя жена, моя, например, сестренка кругом туберкулезно больная, например, страдает. Туберкулезом страдает. Почему? Потом, когда задавали вопрос, там отвечают казахи, говорится, генетически обречены.
Эта фраза не укладывалась у молодого Турегилды Шарманова в голове, и он решил во что бы то ни стало решить эту проблему. И решил. После окончания обучения Шарманов с супругой живет и работает на селе и пытается изменить быт казахов, заставить их соблюдать элементарные санитарные правила. Он ходит по домам, показывает и говорит, как защитить себя от заражения инфекционными заболеваниями. Неимоверный труд будущего академика дает свои плоды. Уровень заболеваемости на селе резко упал. Шарманова переводят работать в город, но односельчане не хотят его отпускать. Этим высоким принципом безвозмездной помощи людям он придерживается до сих пор и призывает к этому молодых медиков. Да, несмотря на преклонный возраст, Турегилды Шарманов является наставником, учителем, почетным профессором ведущего медицинского университета страны КЗНМУ имени Санжара Асфендиярова. Его день начинается ранним утром. Он приезжает в свой офис в Академии питания, следит за работой лабораторий, дает советы сотрудникам и ни на секунду не забывает о работе Академии. Герой медицины признается, что ему бы хотелось больше путешествовать.
У меня много недостатков в этом отношении, способностей, желаемых, например, добиться многого. Я хотел стремиться, я любил, например, по горам ходить, и всегда возможность есть. Но все-таки я успевал много городов обходить. Я люблю путешествовать, добился поездки в Австралию. То есть весь земной шар пришлось мне объездить по делам. Очень интересно, в отличие от туристов. Способность, чтобы практически, если у меня возможность, видать больше новых, интересных вещей и полезных, например, каким-то образом в своей среде, в своей национальности, чтобы их проповедовать, чтобы они могли таким образом. Я люблю путешествовать.
Турегилды Шарманов – настоящий патриот страны, профессионал, достигший небывалых высот, всегда ставивший выше своего здоровья людей. 12 лет его службы на посту министра здравоохранения Казахской ССР называют золотым веком отечественной медицины. В эти годы он создал уникальную структуру здравоохранения, благодаря его организаторским талантам, выдержавшую развал Советского Союза. В числе его заслуг исследования, которые доказали, что Казахстан является йододефицитной страной. Ему удалось добиться обязательной йодизации соли. Еще одна заслуга – это фортификация муки. Жители Казахстана страдают железодефицитной анемией. До 80% женщин на юге страдали анемией и рожали очень больных детей. Сами умирали от кровотечения, массы, акушерско-гинекологических и других осложнений. Железодефицитная анемия была бичом нашей страны. Академик Шарманов, доказав, что существует такая проблема, дал и пути ее решения. Это фортификация муки. То есть вся мука высшего первого-второго сорта несет добавление препаратов железа. Таким образом, у нас в стране железодефицитная анемия сошла с повестки номер 1. А академик Шарманов своим трудом спас сотни тысяч жизней.
Главный недостаток у меня, наверное, и преимущество одновременно. Излишнего доверчивого людям. Это мой, считаю, и практически достоинство для тех, кто хорошо понимает, например, доверием, ценит доверием. А те люди, которые мыслями совершенно недобрыми, им, например, сказать, вот доверять очень опасно. Я много пережил из-за доверия. Из-за этого, например, больше получился скандальных вопросов, кому только не доверял. Понимаете? А я вообще-то человек, поэтому людям, которые пришли ко мне, недоверчиво, я настроен доверять людям. Мой жизненный уклад, принцип доверять людям, понимаете. А я не знаю откуда. А потом сталкиваюсь, огорчаюсь из-за личного доверия.
Ученый с болью постоянно обращается в правительство, поднимая вопросы острой нехватки финансирования науки для проведения необходимых исследований питания казахстанцев, переживает за состояние санитарной службы. Особенно сильно его заботит состояние здоровья детей. Им неоднократно поднимался вопрос исключения из ассортимента школьных буфетов вредных продуктов. Он первым в мире начал доказывать научными исследованиями полезность и ценность кобыльего молока. По сути, создал новый национальный бренд и продвигает его на международной арене до сих пор. Сейчас особой гордостью академика является разработка абсолютно безвредного шоколада на основе кобыльего молока.
Шоколад все население планеты любит, а шоколад грязный. Почему? Потому что там сахар есть. При чем сахар? Сахар как раз грязный, потому что сам по себе какао, масло тертое, оно очень горькое, не могут есть, например. На любителя можно будет, как говорится, поесть, а так невозможно. А я сделал шоколад, например, достойный. Кажется, ничего себе такое. А в этом-то и ключ, чтобы очистить сахар от сахара, чтобы не присутствовал. Шоколад иначе не привлекательный, поэтому я посадил какао-масло на кобылье молоко. Кобылье молоко очень сладкое, поэтому естественная сладость, лактозу. Получается шоколад прекрасный продукт, очищенный от сахара, вредных веществ, транширов. Потому что кобылье молоко не имеет транширы, в отличие от коровьего молока. За это получил премию большую, за новизну этого, именно шоколада, в мире единственного.
Интересно, что каждая победа Торегильды Шарманова так или иначе связана с памятью близких ему людей. На поиск нового рецепта создания шоколада его сподвигла память о любимой супруге. В юности он ухаживал за красавицей и дарил ей шоколад-миньон. Выбор юноши не одобряло его окружение, но хулигану Шарманову мнение окружающих было нипочем. Он уверенно шел к своей цели и не видел никаких преград.
А мне даже обвиняли, зачем на больной девушке женился. Я говорю, я люблю, ничего не знаю, что это больной. Я врач, я должен лечить, помочь. И трижды спасал, я счастливый человек. Больше заботы было о ней, я больше страдал. Но это страдание было счастливое страдание. Именно во имя спасения своей любви. Поэтому, говорят, в казахской среде есть поговорка. Люби жену, говорит, это здоровую, нет, здоровую, а сестру богатую. Я совершенно, у меня сестра была бедная, и жена была больная. Я по любви женился, любил, она больная, но я любил ее. Она родила мне алмаза. Я счастлив, что любил. Что же больная? Ну я же спасал. Я счастлив, что я ее спасал.
Поднимаясь все выше и выше, смотрит Торегильды Шарманов и в космос. Казахская академия питания под его руководством разработала целый класс продуктов для космонавтов. Естественно, это традиционные казахские блюда на основе кобыльего молока, но в вакуумной упаковке. Набор Дастархан-6 состоит из 9 блюд. Среди них сухое кобылье молоко, творог с добавлением ягод и орехов, чай на основе красного корня, восточные сладости и другие десерты, суп-харчо с кониной.
Когда говорят, я хочу облагородить весь мир, так не бывает. Ты сначала сам был достойным, себя обеспечь, потом окружающим давай. Люди врут, ханжествуют, когда говорят, я благотворю всем. Чепуха, это коммунистическое ложное учение было. Прежде всего должен себя. Ты, если не состоятельный, ты можешь ли оказать помощь? Это ложь ведь. Ты никчемный человек, как ты можешь всем дать благо? Тебе должно быть то, что для достойной жизни есть, ты давай, если есть возможность, помогай людям окружающим. Вот так надо.
Он признался, что ни за что бы не изменил свою жизнь и профессию. Академику Торегильды Шарманову 90. Он все так же полон сил, энергии и стремления к новым победам, покорению вершин. Человек-легенда, живая всех живых, легенда и гордость Казахстана. Постоянно ученый поднимает вопрос возвращения к национальным истокам в питании, проведение исследований национальных блюд, которые испокон веков передавались от поколения к поколению, необходимости широко пропагандировать и демонстрировать всему миру историю и богатую культуру казахского народа в области питания. В свои 90 лет Торегелды Шарманов силен и крепок. Он продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, сохраняющим не только волю к новым вершинам, но и желание помочь, поддержать своих подопечных и трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алма-Атинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Торегелды Шарманова.
Алма-Атинская декларация остается исторически великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это и было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Торегелды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Торегелды Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегильды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их назвали бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровьем населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железно-дефицитную анемию. Я возглавлял эту кампанию.
А главное, Турегильды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегильды Шарманову в первый и последний раз поступиться своей совестью. Он дал интервью зарубежному изданию, где заверил мировую общественность, что права человека в Советском Союзе не нарушаются. Это вызвало шквал нападок на Шарманова и даже угроз. Недоброжелатели предрекли провал Алматинской конференции, а ему самому крах карьеры. Он рисковал, но не отступил. Всемирная конференция в Алма-Ате состоялась, сбылась мечта ее идейного вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алма-Атинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегильды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека, создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока, даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский, на кобыльем молоке. Сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский шоколад. Она во многом чище, добрее. Почему? Потому что на кобыле молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегелды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Турегелды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алматинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алма-Атинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Турегелды Шарманова.
Алматинская декларация остается исторически великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Турегельды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Турегельды Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегельды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их называли бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровьем населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железодефицитную анемию. Я возглавлял эту кампанию.
А главное, Турегельды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегельды Шарманову в первый и последний раз поступиться своей совестью. Он дал интервью зарубежному изданию, где заверил мировую общественность, что права человека в Советском Союзе не нарушаются. Это вызвало шквал нападок на Шарманова и даже угроз. Недоброжелатели предрекли провал Алматинской конференции, а ему самому крах карьеры. Он рисковал, но не отступил. Всемирная конференция в Алма-Ате состоялась. Сбылась мечта ее идейного вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алма-Атинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегельды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека. Создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока. Даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский. На кобыльем молоке сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский шоколад. Она во многом чище, добрее. Почему? Потому что на кобыльем молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегельды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Турегельды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алма-Атинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Т.Ш. Шарманова.
Алма-Атинская декларация остается исторической великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Т.Ш. Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Т.Ш. Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегельды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их назвали бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровьем населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железно-депозитную анемию. Я возглавлял эту кампанию.
А главное, Турегельды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19...
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегельды Шарманову в первый и последний раз поступиться своей совестью вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алматинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегельды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека. Создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока. Даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский. На кобыльем молоке сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский шоколад. Она во многом чище, добрее. Почему? Потому что на кобыльем молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегельды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Торегильды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алма-Атинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Торегильды Шарманова.
Алма-Атинская декларация остается исторически великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Торегильды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Торегильды Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегельды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их назвали бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровье населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железно-дефицитную анемию. Я возглавлял эту кампанию.
А главное, Турегельды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегельды Шарманову в первый и последний раз поступиться своей совестью. Он дал интервью зарубежному изданию, где заверил мировую общественность, что права человека в Советском Союзе не нарушаются. Это вызвало шквал нападок на Шарманова и даже угроз. Недоброжелатели предрекли провал Алматинской конференции, а ему самому крах карьеры. Он рисковал, но не отступил. Всемирная конференция в Алма-Ате состоялась, сбылась мечта ее идейного вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алма-Атинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегельды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека. Создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока. Даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский. На кобыльем молоке сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский шоколад. Она во многом чище, добрее. Почему казах? Потому что на кобыле молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегелды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Турегелды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алматинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алматинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Турегелды Шарманова.
Алматинская декларация остается исторически великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Турегельды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Турегельды Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегельды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их назвали бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровьем населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железно-дефицитную анемию. Я возглавлял эту кампанию.
А главное, Турегельды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегельды Шарманову в первый и последний раз поступиться своей совестью. Он дал интервью зарубежному изданию, где заверил мировую общественность, что права человека в Советском Союзе не нарушаются. Это вызвало шквал нападок на Шарманова и даже угроз. Недоброжелатели предрекли провал Алматинской конференции, а ему самому крах карьеры. Он рисковал, но не отступил. Всемирная конференция в Алма-Ате состоялась, сбылась мечта ее идейного вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алма-Атинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегилды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека, создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока, даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский, на кобыльем молоке. Сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский. Она во многом чище, добрее. Почему? Потому что на кобыльем молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегилды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Турегилды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на до и после. Настолько велико было значение Алма-Атинской декларации, провозгласившей лозунг «Здоровье для всех» к 2000 году. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Төрегелді Шарманова.
Алма-Атинская декларация остается исторически великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной.
Құрметті Төрегелді Шарманова, бүгінгі халықаралық конференцияны бастауға рұқсат етіңіздер. Мы рады приветствовать вас на международном.
We are very pleased to welcome you at the scientific conference dedicated to the 19th anniversary of the academician Каиргилди Шарманов, the author of Magna Carta of Primary Health Care, as well as the 19th anniversary since establishment of the Kazakh Medical University. This event is dedicated to these two events. And among other events, we will have, apart from this conference, the role of the primary health care in controlling COVID-19. We, under this event, managed to gather prominent medical practitioners and researchers from various countries who will share their best practices in this regard. Distinguished colleagues, let me give the floor to the Minister of Public Health of the Republic of Kazakhstan, Mr. Tsoi. Distinguished academician Sharmanov, Mr. Mayor, members of the Presidium, distinguished colleagues, let me start the conference with a congratulatory note to the academician Sharmanov. Distinguished Mr. Sharmanov, we wish you good health and further success in your scientific career.
So, on behalf of UNICEF and other international organizations, we would like to underscore your efforts for international cooperation and collaboration in scientific and academic circles. As a member of Kazakh Academy of Science, we wish you all the success and would like to note your input into the development of Kazakh medical science and research at the international frontiers. We wish you good health, and on behalf of the President Kassym-Jomart Tokayev.
Distinguished Khairgildi Sharmanov, your career from the head of the rural health post to the Minister of the Republic of Kazakhstan on public health is truly astonishing. Your accomplishments are recognized by the World Health Community. For many years you remained on the vanguard of the practical medicine and in primary health care in particular. Due to exclusive persistence and your personal contribution, in 1978 in Almaty, the historical event, the primary healthcare conference took place in Almaty, Kazakhstan, and Almaty PHC declaration was adopted there. And today the issues of PHC, the keystone, is the keystone of the medical practitioners' development. And now we are having this conference, which is another big step forward in understanding the issues of the PHC. Now I would like to give you a diploma on behalf of the President of Kazakhstan, Kassym-Jomart Tokayev. Many thanks, Alexei Vladimirovich. Here with us we have the Akim of our city, the mayor of Almaty, Baketjan Sagintayev. Good morning, distinguished colleagues, distinguished Kaygerdei Sharmanov.
Today we have gathered here to celebrate the birthday and anniversary of distinguished academician Sharmanov, and it was already noted the tremendous efforts that Dr. Sharmanov have inputted into the forming of Almaty Declaration of Public Health here in the city of Almaty in 1978 in the conference which was organized jointly by UNICEF and WHO. And today we have gathered here under the auspice of the Almaty Medical University, named after Asfendiyarov, which has been an alma mater of many prominent Kazakh medical scientists and scholars and practitioners. And today we have gathered here both young and old generation of doctors and scientists and healthcare practitioners, as we are combating now the COVID-19 pandemics. We have gathered here to discuss the most important issues in this development. And you know that when the roses were given, the academician Sharmanov has said that they smell beautifully. That means that there are no symptoms.
We have already mentioned the historical 1978 Almaty Declaration, and we commemorated this event in Astana in 2018, 40 years after the Almaty conference. This was a very good opportunity to tell the world about the principles which were adopted 40 years ago in Almaty. Now we see how these principles were right when the main focus was made on the primary health care. This is specifically important during the times of the current pandemic. So we are arguing quite often with my son regarding hospitals' bed and their importance in fighting the COVID-19, but we know that it is difficult to overestimate the role of the PHC considering the situation with the current pandemic. The main focus today is in detecting and monitoring of infected people, and this job is done by the PHC practitioners. And I hope that this sphere will be developed further on, and this is very symbolic that next to you we have our young and ambitious Minister of Health, and I hope that this is a very symbolic event, that two ministers are sitting next to each other, and this is not only our old men, and but this is a source of the current knowledge about the primary health care. And I wish you everything great and good health. And I know that the dreams of our young health practitioners would come true because of your foundation, which you laid to the health in Kazakhstan. Wish you good health again and everything great. Many thanks, Mr. Akim, and now I would like to give a floor to academician Torgildy Sharmanov. I want to wish you happy birthday again, and now the floor is yours, please. Dear Bakhitjan Abderalou, Alexey Vladimirovich, Talgat Sejanuli, this conference is quite important. Today we celebrate the 19th anniversary since the establishment of my alma mater, Kazakh National Medical University, and my birthday. This is a very important, considering the fact since that Almaty Declaration had been signed also here in Almaty. Almaty Declaration was adopted on the 12th September 1978 at the final day of the International Conference on Primary Health Care, which was under the slogan Health for Everyone. Irrespective of the seeming utopian nature, this motto and the principles played a colossal role in the development of the world healthcare. Almaty Declaration, it became a history as a Magna Carta of the public health. These 3 pages had only 10 points. However, these were fundamental principles of healthcare, focusing on the birth rights of every individual as well as the responsibility of every citizen for their health. It was mentioned in the declaration that all resources should be mobilized for providing safe environment as well as water, food, and adequate conditions for healthy maternity and childhood, medicine provisions. Although these principles are very obvious, 42 years ago they changed the priority of healthcare for many world countries, determining the development of the primary healthcare, the PHC, which now are the main priority, is the main priority. Well, then I was a Minister of Health in Kazakhstan, and that was a historical mission for me, not to be the initiator, but the key organizer of that historical conference where the famous Almaty Declaration was adopted. In 2005, 27 years after, for success of the conference, I was awarded by the international premium named after Leon Bernard, the top award by the WHO. On 6 to 12 September 1978, to Almaty, we've got about 1,000 delegates from more than 100 world countries. This was a unique international event for Kazakhstan, where at that time, rare foreign guests coming over. And here, all of a sudden, more than 1,000 foreigners came to Almaty, among those American Senator Kennedy and wife of a Shah, Verana Shraf Pehlevi. Almaty conference changed our understanding and consciousness, where before we had the so-called disease-centric paradigm. We focused on new drugs and medical technologies. However, what we try to do now is, at that time rather, according to the old paradigm, we were actually fighting with the consequences rather to be focused on the main reasons of bad health. Perspective of various developments of new technologies and new accomplishments in physical, mental, and social health, millions of people are yet suffering because of bad health. What are the reasons for this paradox? As a matter of fact, we're always trying to forget on the key role of prophylaxis and early detections of diseases. This is what we called as primary health care. That is why 41 years ago, in 1978, historical Almaty Declaration by WHO changed the understanding that health is provided not only by physicians who just cure diseases in a much more degree. That is because of the preventive measures such as good food, clean environment, high-quality water, vaccination, and safe maternity. These measures should be done not only through hospitals, but at the Felcher points in polyclinics, which are close to the domicile of most citizens. In other words, at the PHC level. Almaty Declaration also underscored the PHC as a main tool for accessing high-quality, affordable medical services for all. In other words, we are talking about affordability, availability of medical health to everyone, irrespective of social status or health status. This was the key ideological point of the declaration, which for many years was thinking over by Halfdan Mahler, General WHO Secretary. He was born in Denmark in a religious family. He was irrespective of his religious religious background, never preaching, but his missionary spirit played a very important role in his position. After accomplishments of Medical University in Copenhagen, Mahler focused on fighting with TB and other infectious diseases in Ecuador, India, and other developing countries. He at that time was with the Red Cross Society. At that time, Milo realized that it is impossible to reach success focusing exclusively on a vertical program on controlling the above-mentioned diseases. Not a single drug or vaccine will not be successful or effective if the program would not be supported by the needed infrastructure of healthcare or social support for the public.
So it was important to protect from the diseases by developing horizontal programs of healthcare and preparation of training of personnel and building of hospitals. It was too expensive, so it was decided to concentrate resources on not expensive measures for prophylactics and prevention of diseases that could be organized on the level of the primary health care. And that's why, dear Mr. Mayor, at that time, together with my colleagues, I was against the construction of hospitals in Almaty and other cities. And I'm still convinced that that was a wrong move, that we should have developed the primary health care even more and not to concentrate on the building of hospitals, because that is against the spirit of the conference which we are celebrating the 40th anniversary. That's why I was against it. And United States of America was against this, as well as a number of other countries which have been preoccupied with individual approach, and that quality health care should be earned, and free services brings the spirit of idleness. One of the few from US who were supporting the universal access to care was legendary Senator Edward Kennedy. He came to Almaty to gather his supporters in order to influence American public opinion, and I was blessed to meet this person. I have met him in the airport, and I was seeing him off. So it was very interesting from today's perspective. And during that time, it was a very new idea. The health for all was dominating and quite popular in the world. And based on that platform, Halfdan Mahler was elected Director General of WHO. And the health for all idea, implementing this idea, he decided to start with an international conference, which is to adopt the Declaration on Primary Health Care. And unsurprisingly, the country to host this universe was chosen to be the Soviet Union, which already had quite developed network of primary health care as the polyclinics and other outpatient facilities. So it was important to select the place in the Soviet country which would reflect the realities of developing countries. And a good candidate from that time was Tashkent, the capital of Uzbekistan. And at that time it was considered cultural and intellectual capital of Central Asia. And at that time Tashkent already had necessary infrastructure to conduct international forums of such scale. So in order to choose the location, WHO management decided to visit first Tashkent and just in case to visit Almaty. They have spent 3 days in Tashkent and 1 day was planned for Almaty. That was headed by the Deputy Director General, Mr. Thomas Lamba. And during the visit to Kazakhstan, for 1 day only, we were able to convince the delegation to host this event, and I was convincing, first of all, the Ministry of Health in USSR that he was claiming that we would fail this conference. So I had to apply a lot of efforts and to have the leader of Kazakh government of Kazakh Republic in USSR, Mr. Kunaev, and that's how I was able to persuade them. So now we had to convince that Almaty is able to host this conference, and they were preliminarily selecting Almaty, Tashkent, Tbilisi, Baku, and Novosibirsk as 5 cities, and all these 5 cities were visited by delegates from WHO and UNICEF, and after 10 days they said that the best location would be to host this conference in Almaty. So that was the result of the difficult struggle for hosting this conference, and it was the struggle with the entire world. So I'm proud that we were able to secure this location for Almaty. And in 1978, I have hosted the leaders of World Health Care at home to celebrate the 45th anniversary of my wife, her birthday. And while we were celebrating at the kitchen, Dr. Carl Taylor, professor of Johns Hopkins University, was charting the final version of Almaty Declaration, the Health for All by the year 2000. And at that time, they were saying that Almaty Declaration was adopted at Sharmanov's kitchen and was later approved by the entire world. And Almaty Declaration started to parade throughout the world, and many countries have taken this as the basis for their national health care. And in Russia, in Brazil, the text of this declaration was fully adopted to be a part of the constitution. But later, the initial enthusiasm was changed to skepticism. That was due to the fact that many issues of this document were only declared and were in fact ignored, such as the 7th principle of Almaty Declaration says that the public have right and the duties to actively participate in their health management, both individually and collectively. The declaration also says that development of the primary health care provides for the independence of individuals and communities and their increased responsibility and active participation in making decisions related to their health. And the role of citizens and communities, their responsibility for their health, was not duly taken in consideration. The main responsibility was given to the public structures, which, as it is well known, greatly depend on the presence of resources and subject to political and other influences. And a lot of the funds are spent for hospital services, and the result of such approach is ineffective use of resources, the growing number of chronic diseases, and as a result, increasing costs for health care. To that we should add the problems of aging population, pollution of the environment, as well as the new and newly awakened infections. That is ever growing the costs, and it's the huge burden on healthcare. The reasons for such policy have shown that its inadequacy in fighting current coronavirus pandemics. The primary health care was mostly absent from the process of diagnostics, early detection, epidemiological surveillance, and providing care to the patients with COVID-19. Persons that were infected with coronavirus without any symptoms were unaware of what to do. There were no places in the hospitals. They were getting medical consultations by WhatsApp. And that was done not by doctors most often, but antibiotics were given without any procedure, such as dexamethasone, anticoagulants, and other unsafe drugs. So there was a great shortage of drugs, and as a result, there was chaos, confusion, and even panic among the people. At that time, the warehouses were stored with drugs, but those drugs, the medicine, they were hidden. That was a crime, and people were dying, whereas on the warehouses there were huge stockpiles of drugs. The solution is to focus on the primary health care and disease prevention. This strategy will help to effectively distribute and to curtail the ever-growing costs on health care. And that provides for the prevention and prophylactics. And it's important to use the team approach, where the key issue is to involve all the players and consumers of health care services. And that includes all doctors and nurses, and not only narrow specialists. At that time, there was a legend of the help of bare feet doctors from the developed countries. That's why it was used to save the lives. Even during lockdown, it is very important to provide access to health care for the public, not only those that are infected with COVID-19. We should not ignore the importance of planned prophylactics and prevention for all the patients, including children, pregnant women, and those who are suffering from chronic non-infection diseases, and that should be coordinated on the level of PHC. Today, the world is seized by unprecedented pandemics. Fighting this would require unusual solutions and substantial investment in the future of public health. That is a unique opportunity to go away from obsolete stereotypes and to implement a new paradigm of healthcare. In order to fight the next wave of pandemics, we need a complex, differentiated, and balanced approach to pandemic surveillance. For that, we need trained, qualified personnel of sanitary doctors. In order to optimize our education system, in our institutes and schools, we had sanitary and hygiene faculty. That was closed. We don't have sanitary doctors anymore. So, as we have here the minister and the leadership of our country, we should restore sanitary and hygiene faculty. And that was not only my request, but I am preoccupied with the state of our population. It's in critical condition, so we should restore that which was lost. And unfortunately, we need to go away from disease-centered care to the alliance with the patients in order to prevent the diseases being equipped with the tools to fight the disease and to prevent it. And that would provide for the long and healthy life of our citizens. In order to develop such a system, we can create a wide opportunities to improve the quality of life of our people. That is witnessing the fact that Almaty Declaration is not a dogma or utopia. The declaration ideas should be rethought in order to tailor them to specific political situation and the level of involvement of the public and the development of technology. Thank you for your attention. Many thanks, Academician Шарманов. Next, we'd like to show a video, a film.
Из самых передовых для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Турегельды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов
Ladies and gentlemen, I have the honor and privilege to read to you the Declaration of Alma-Ata.
Звучат слова итогового документа конференции Алма-Атинской декларации.
12 сентября 1978 года. Эту дату человечество запомнит как день, разделивший историю медицины на две. Международная конференция по первичной медико-санитарной помощи проходила под эгидой Всемирной организации здравоохранения и ЮНИСЕФ. Делегаты из 146 стран мира, 67 международных организаций, сотни аккредитованных зарубежных журналистов, известные государственные и общественные деятели, среди которых сенатор Эдвард Кеннеди и шахиня Ирана Ашраф Пахлави. И тем более удивительно, что это событие произошло в советском Казахстане, его столице Алма-Ате. За право провести форум такого уровня боролись несколько городов мира. Советский Союз предложил Ташкент как город с огромным опытом проведения масштабных международных встреч, но неожиданно для всех победила Алма-Ата, а точнее победили убежденность, упорство и харизма одного из ключевых организаторов конференции, в тот период министра здравоохранения Казахской ССР Турегельды Шарманова.
Алматинская декларация остается исторической великой хартией мирового здравоохранения. Именно за здоровье нации, за здоровье человека. Приняла декларацию, обязывающую государство обеспечить право человека на здоровье. Вот это было, между прочим, та борьба, в которой я играл одну из важных ролей. Добился и провели, причем это реализовалось, я счастлив.
Сегодня трудно представить, что пришлось пережить Шарманову в те дни. Сначала ему пришлось сломить сопротивление руководства Министерства здравоохранения СССР, потом убедить первого руководителя республики Динмухамеда Кунаева в том, что лучшее место для проведения международной конференции – Алма-Ата. И не только потому, что это красивый, уютный, современный город. Здесь лучшие в стране санатории, больницы, поликлиники, детские клиники, фельдшерско-акушерские пункты. Словом, все то, что могло продемонстрировать зарубежным коллегам советскую модель здравоохранения, а система оказания первичной медико-санитарной помощи в СССР была на тот период одной из самых передовых. Для Шарманова важно было показать не только парадную сторону советской медицины, но и привлечь внимание к ее проблемам. О них он знал не понаслышке. Турегилды Шарманов прошел все ступени медицинской службы, от сельского врача до министра. В 1958 году, окончив Карагандинский медицинский институт, он вместе с супругой Кульзией отправился в сельскую глубинку, село Улытау. Здесь, в этих сказочно красивых местах, где все дышит историей, героическим прошлым казахского народа, он родился. Здесь он впервые задумался о том, как помочь людям бороться с недугами, как продлить их жизнь. До казахских аулов, разбросанных по степи, удаленных от городов на сотни километров, медицинская помощь не доходила. Многие сельчане не знали, что такое рентген. Отсутствие чистой воды, полноценного питания, суровые условия жизни привели к тому, что среди казахов, живущих в аулах, было много больных туберкулезом, бруцеллезом, цингой и другими социальными болезнями. Особенно много умирало детей до 5-летнего возраста. От воспаления легких умерла младшая сестра Турегилды Шарманова. Эта личная трагедия определила выбор его профессии. Когда супруги Шармановы прибыли в родное село, они увидели, что ничего не изменилось. Та же нехватка врачей, те же болезни и проблемы. Турегилды был назначен главным врачом местного медпункта. Кузия, фтизиатр, рентгенолог. Но фактически Шармановым пришлось стать универсальными специалистами. Сегодня их назвали бы семейными врачами. Они получили бесценный опыт работы педиатра, акушера-гинеколога, хирурга, терапевта. Шармановы смогли открыть молочную кухню для детей, улучшили условия работы медицинского персонала.
Я боролся в свое время против таких роста, йододефицита. И добился. 100%, например, это благополучие населения. Это мое счастье, это первый успех. Избавил от многих болезней казахов. В первую очередь, потому что казахи это не совсем недопонимали. Поэтому первый большой проект, который завершился победой, улучшением здоровья населения планеты, это был проект, который я проповедовал, я добивался этого. Это счастье, здоровье. Основа счастья, здоровья. Если я смог в чем-то помочь сделать здоровье населения планеты, помог здоровью, я счастлив. И поэтому мое счастье, что я смог добиться того, чтобы ликвидировать железно-дефицитную анемию. Я возглавлял эту кампанию.
А главное, Турегилды на собственном опыте понял, как важен первичный контакт врача и пациента, то, что называют первичной медико-санитарной помощью. Медицинская помощь должна дойти до каждого, кто в ней нуждается. А еще он усвоил, что болезнь лучше предупредить, выявить на ранней стадии. Эти принципы позже были озвучены в Алматинской декларации.
I am infinitely proud and delighted that the triumphant victory of the 19
Алматинская декларация впервые провозгласила право на здоровье каждого человека, независимо от возраста, уровня достатка, социального положения и места жительства. Оно является его неотъемлемым правом, так же, как и право на жизнь, на свободу. Этот пункт и пытались использовать противники Алматинской конференции, указывая на отсутствие политических свобод в Советском Союзе. Тогда и пришлось Турегилды Шарманову в первый и последний раз поступиться своей совестью. Он дал интервью зарубежному изданию, где заверил мировую общественность, что права человека в Советском Союзе не нарушаются. Это вызвало шквал нападок на Шарманова и даже угроз. Недоброжелатели предрекли провал Алматинской конференции, а ему самому крах карьеры. Он рисковал, но не отступил. Всемирная конференция в Алма-Ате состоялась, сбылась мечта ее идейного вдохновителя Халфдана Маллера, генерального директора ВОЗ. Именно его идеи легли в основу Алматинской декларации. Он предложил выработать единую стратегию в области охраны здоровья населения развитых и развивающихся стран мира, направить усилия и ресурсы медицины на недорогостоящие меры профилактики и предупреждения болезней, оказать внимание первичной медицинской помощи. Человек ответственен за свое здоровье, и в то же время государство обязано обеспечить ему доступ к медицинской помощи. В Алма-Ате впервые были озвучены пути тесной интеграции систем оказания медицинских услуг в мире. Был утвержден приоритет материнства и детства, межведомственный подход. Обращалось внимание на развитие национальных систем здравоохранения. Глобальная цель Алма-Атинской декларации – достижение к 21 веку всеми народами мира такого уровня здоровья, который позволит им вести продуктивный в социальном и экономическом плане образ жизни. Прошло больше 40 лет. Многие принципы Великой Хартии мирового здравоохранения стали основой деятельности врачей разных стран мира. Медицина стала другой, ближе к человеку. Жизнь Турегельды Шарманова после 1978 года тоже разделилась на до и после. Успех, победу дерзкого министра не простили. Он был вынужден покинуть пост и уехать в Москву. Спустя несколько лет ему вручили высшую награду в медицине – международную премию ВОЗ имени Леона Бернара. Вернувшись в Казахстан, Шарманов обратился к вопросам продления жизни человека. Создал Казахскую академию питания, где разработаны уникальные продукты из кобыльего молока. Даже шоколад и питание для космонавтов. По сути, это национальный бренд, который высоко оценили в мире.
Шоколад, вообще, между прочим, всеми любимыми продуктами всей планеты. Я хотел, чтобы шоколад был казахский. На кобыльем молоке сделал казахский шоколад. И признали этот казахский шоколад. У всех на устах швейцарский шоколад, французский, британский шоколад. А теперь на устах будет казахский шоколад, казахский шоколад. Она во многом чище, добрее. Почему казах? Потому что на кобыльем молоке. Потому что казах сделал.
Академик Шарманов продолжает реализовывать в жизнь главные принципы Алматинской декларации 1978 года, понимая, что 21 век принес человеку новые вызовы. Все больше появляется болезней, связанных с неправильным образом жизни, со стрессами современного технологического мира. Поэтому так важны для людей полноценное питание, чистая вода, своевременная вакцинация, безопасность материнства. Об этом он часто беседует со студентами в Казахском национальном медицинском университете имени Асфендиярова. Вот уже 90 лет здесь готовят кадры для медицинских учреждений Казахстана. Это те самые врачи, доктора, которые лечат и будут лечить жителей городов и сел его необъятной родины.
Мы сверстники, мы в один год родились. Оба парня, если можно сказать, родились в 30-м году. Я счастлив, что открыл двери медицины именно медицинский институт Алматинский. Мы гордимся, я лично горжусь, что именно в Казахском медицинском институте начал учиться. И сейчас работаю на развитии этого медицинского института.
Турегельды Шарманов – ровесник университета, ему 90 лет. Всей своей жизнью он доказал верность профессии и знаменитому принципу мировой медицины – здоровье для всех. О возрасте он говорит философски: годы – это всего лишь опыт жизни, возможность жить мудро, качественно, творчески.
Счастье человека, когда сделаешь добро людям. Вот это мой девиз. Я счастливый человек.
В свои 90 лет Турегельды Шарманов все так же полон сил, энергии, стремления к новым победам, покорению вершин. Продолжает быть несомненным лидером в сфере здравоохранения, примером для коллег, наставником для молодых ученых и медиков, который продолжает ежедневно трудиться во благо родного Казахстана. Летят года, сменяются поколения, но по-прежнему в ногу со временем идет он, наш неизгибаемый, непобедимый, легендарный Токе.
First of all, what we said, whether to build hospitals or exclusively relied on the primary healthcare facilities. Why we're arguing about this? During the pandemic, it is quite evident regarding the status and the capacity of our hospitals, whether they are up to the requirements of the current situation. And if they are not well equipped, then we need to carry this oxygen cylinders. That is why we need to be focused on improving capacity of the new hospitals which will be equipped up to the world standards. Secondly, you probably were not informed regarding the fact that the warehouses were full with the so-called hidden drugs, but this is not right. At the end of July and June, beginning of July, I personally monitored the situation on drug supply with the main distributors which are based here in Almaty, and we know specifically which drug available in which warehouse, and we manually managed to distribute this. And to say that drugs were available on the warehouses but not available for the patients is not right. The government supplied drugs with airlift from Russia, from India, in big volumes. Drugs started to provide it to our cities. So government was not hiding drugs. Please understand me clearly, the respective representatives of the media. You were right that it was a chaotic situation at that time, and even thermometers were supplied in big quantities. Even distributors acknowledged that they managed to sell off their 6-month supply of thermometers in a big drugstore. In one of the big drugstore survey proved that customers were at that time buying drugs and thermometers at the request of their relatives. So drug supply was in higher volumes in Almaty than in other cities. No one was hiding drugs at that time. I just would like to clarify this. Thank you very much, Mr. Sagintayev, for your comments. And with this, let me start our morning session. And now I would like to give a floor to Madam Melitta Yakabs. She is head of geographically dispersed office on primary health care by WHO here in Almaty. And now
today's conference. It's
Good
really
morning.
an honor for me to participate and contribute to this event. My name is Melitta Yakab. I'm the head of the WHO European Center for Primary Healthcare located here in Almaty. And I would like to introduce to you my co-moderator, Dr. Kwanish Karibayev, the Dean of the School of Public Health of the Kazakh National Medical University. I would like to start by adding my voice to this beautiful choir. On behalf of the WHO Regional Office for Europe, I would like to add my voice to this beautiful choir we heard this morning to congratulate Professor Sharmanov for his 90th birthday. WHO greatly values Professor Sharmanov's leadership and historical contribution to the ideals of public health and global health. I personally cannot imagine my life without the Alma-Ata Declaration. The Declaration has also created the foundation for Kazakhstan's leadership in public health and primary health care and universal health coverage that continues today,
Can you hear me?
not only at the regional, but also in the global arena.
Hello.
The ideals of the Alma-Ata Declaration really came under the test in the past 10 months. And I'd like to thank the Kazakh National Medical University for pulling this event together to think about the very important role that primary healthcare can play in the COVID-19 pandemic.
Hello, can you hear me?
Some
I can't
countries
hear
have
anything.
taken a great advantage of the very widespread primary healthcare networks in their countries and involved primary healthcare in the fight against COVID-19. For example, in contact tracing, in practicing and supporting isolation and quarantine measures, managing the mild and moderate cases, and even in rehabilitation. At the same time, there is a huge role for primary healthcare to maintain access to essential health services even during the pandemic, because people continue to break their arms, people continue to have babies, people continue to have chronic conditions. And this is indeed an enormous, enormous role and burden. Today, we're going to hear very exciting experiences from the world, from New Zealand, from Japan, from Singapore, from Kazakhstan and Lithuania, and learn how different countries have involved primary healthcare in the fight against the pandemic and maintaining essential health services. Before I introduce our first speaker, I would like to say those of you following the conference online that your participation matters. Please post your questions in the chat line, and my co-moderator will be monitoring closely the chat line, and we will be able to give your questions to the speakers right after their presentation. With that, I would like to introduce our first speaker, Professor Michael Beyker, Professor of Public Health at the University of Otago, New Zealand. Professor Beyker, the floor is yours.
Thank you. I feel very honored to be invited to this very important event dedicated to the 90th birthday of Professor Sharmanov. And I'm very aware of the huge significance of the Alma-Ata Declaration. It's something that I think all of us working in public health have grown up with, and it was such a significant event. So today I'm going to pick up on the theme of how different countries are responding to the COVID-19 pandemic. And this presentation is very much about the New Zealand response, and we took an elimination approach. So I'm going to just describe that in some detail. And just a bit of background about me. I'm a professor at the University of Otago in Wellington. That's the first medical school in New Zealand. I've been working in public health long enough to have had a number of previous experiences with pandemics. Initially with HIV/AIDS and setting up the needle exchange program in New Zealand to prevent HIV getting into the injecting drug user population. SARS had very little impact on New Zealand, although obviously we were very aware of it. We had a very small number of imported cases. The last influenza pandemic was obviously a huge event, but of course it turned out to have, as we all know, relatively low infection fatality risk. And now COVID-19, of course, which I think has clearly dominated the work of public health scientists and agencies across the globe. So today I'm going to talk about the New Zealand response, and some of this is very generic in the sense of looking at frameworks for how we look at pandemics, and some of it is quite specific to the New Zealand setting. So I'm going to go through assessing pandemics, the choices that countries make, what the elimination strategy is about, the impact of the strategy in New Zealand, and some of the key lessons from the response. So as we know, when we look at pandemics and outbreaks, over time we can see these quite consistent questions that come up in terms of the impact they have on population health and social and economic well-being, the fact they generally increase inequalities, and as we all know, there is considerable uncertainty and unpredictability, particularly early on in a pandemic. In general, and as we've discovered with COVID-19, they are controllable. And in many ways, the resulting epidemiology we see around the globe is more related to the human response than the inherent qualities of the virus. And they can, of course, have the potential to create panic and outrage, as we have seen in some countries. Hopefully these are not a major feature. So just going back to the really basic concept, the core idea is, of course, an epidemic, more cases than you expect. And these may be localized as in an outbreak or widespread in terms of a pandemic. And of course, this is not to scale. Pandemics are fortunately rare compared with outbreaks. So when we think about pandemics, I'm sorry, this slide has got a lot on it, but we can think of the idea of a typology of pandemics. We can think of pandemics where the transmission is between people, often with a short to medium incubation period. Pandemics that are characterized by asymptomatic transmission and often long-term incubation periods. And then pandemics predominantly from animals, vectors, food and water. And just to illustrate the fact that we can see pandemics in all of these categories, I've just marked what has been the designated public health emergencies of international concern. And as we know, this is a very distinct designation under the international health regulations. And we can see that if we look down the slide here, we can see obviously we've now had our third significant event from a coronavirus. And we've also seen recurring diseases like polio, Ebola, and also Zika. So we can have diseases that are capable of pandemic spread across a wide range of categories. And I'm partly showing a slide to illustrate the fact that with our pandemic preparedness, we need to have an approach that's sufficiently flexible that it can cater for a wide range of scenarios. There are other elements that we need to think about when we're looking at a pandemic. Obviously, transmissibility is something we hear about very early on, because by definition, a pandemic has to result in widespread transmission, crossing borders and potentially infecting all countries on the globe. So we can assume that relatively high transmissibility is a defining feature, and we obviously can mathematically quantify that with the basic reproduction number. But the other key dimension that determines the public health impact, of course, is severity, with case fatality risk and the infection fatality risk, of course, is what we really want to know, and that's going to give us an idea of whether an agent that may be very transmissible is important or not. And the infection fatality risk may take us a while to measure. There are other elements that are very important, the level of inequalities and controllability. And again, this is something we don't always know about at the beginning, and we can make assumptions about controllability that may or may not be correct. And we have other elements that feed into this decision about controllability, the feasibility of the response and its acceptability, and the economics of the cost of action and inaction. And one of the things I think is always challenging is to work out what the counterfactuals are. So what's the consequence if we don't act, or if we act in certain ways? And this can be very hard to know about, particularly early on in a pandemic. And this really relates to one of these other major defining features, which is the certainty of science information, and why it's so important to have the capacity to evaluate pandemics quickly. So like most countries around the world, we did modelling for the Ministry of Health in New Zealand to work out, based on the known characteristics of COVID-19, the pandemic early on, and we estimated that based on the likely proportion of the population who'd be infected and the known infection fatality risk, that this could result in deaths for about 0.3% of the population. So it's very much more severe than influenza, the equivalent of roughly 25 seasonal influenza seasons all at once. So a key factor in New Zealand is concern for the health of the indigenous people of New Zealand. The Maori population are about 15% of the people in New Zealand, but they have had a very poor experience with prior pandemics, and this is looking at the rate ratio for death for Maori in 3 pandemics across a century. And even as recently as 2009, Maori were far worse affected by influenza than the European majority. And that's a major concern in New Zealand, is ensuring an equitable health system. So for me, and I think probably for others, there were these, what we call, you can think of these light bulb moments when you suddenly become aware that something is serious and of concern. And for me, I think late January, looking at one paper in particular, indicating that this pandemic was going to be a global pandemic, and that was really apparent by late January. But then I think a remarkable report at the end of February, this is the joint mission from the WHO and China, that really described how China had interrupted this pandemic and stopped transmission. So it showed that it could be contained and eliminated. And this was very important for my own thinking and other public health doctors in New Zealand, that we should think about containing this pandemic. And then in mid-March, New Zealand started to switch to having sustained local transmission. And many of us then realized we didn't have the resources for testing and contact tracing to contain the pandemic. So like many countries, we had a pandemic plan. It was a pandemic influenza plan, and it was all about flattening the curve and reducing the impact, but it wasn't about stopping the pandemic. So instead, we switched to an elimination approach. And infectious disease epidemiologists are very familiar with this framework. Generally, you're controlling diseases, but elimination is reducing to zero in a defined area the incidence of a disease. And we have elimination strategies for a number of diseases, obviously polio, measles, rubella. And eradication, of course, is the ultimate extension of elimination, which is reducing to zero at a global level. So this again, sorry, is quite a complicated slide, but we were basically saying in your pandemic planning process here, this was the path we were heading down, a mitigation approach as for influenza. I think there was a realization early on, particularly in Europe and North America, that actually mitigation was not going to work very well and was going to result in too much health damage. And so countries went to a suppression approach. In New Zealand, we decided to go straight for an elimination strategy and that was to exclude disease and eliminate chains of transmission. And we were looking east to Asian countries that were successfully doing this, with the goal being the exit path being to return to a carefully managed new normal after around about 3 months. And that's what New Zealand has done to a reasonable extent. So we developed an elimination strategy and we published this. It's online in a number of sources. And this was adopted by the New Zealand government when they effectively put the country into a very intense lockdown when we only had 100 cases in New Zealand and no deaths at that point. And this in a way is the reverse of what you do with mitigation, where you gradually increase the response to take the peak, to flatten the peak. Instead, we were throwing everything at the pandemic response when we had only a very small number of cases. And that's really the mark of the elimination approach. When you think about what you can do, many of you will be very familiar with the idea of lowering the reproduction number, and it's driven by these 3 elements: reducing transmissibility, contact rates, and ideally the duration of infectivity. We can't currently alter this, but we can alter these 2 components here, and that brings in all of the traditional tools, the non-pharmaceutical interventions of physical distancing, mask wearing down here, and so on. So the components of the elimination strategy was excluding cases at the border, the keep it out approach, border management, case and outbreak management. This is stamping it out with high volume testing, contact tracing, isolation and quarantine, and then reducing transmission with hygiene measures and masks, and this physical distancing and travel restrictions, which of course could escalate up to being a lockdown. And so this is showing these components, border management. This is showing typically the number of people who would arrive in New Zealand each day, 15,000 say, and that was suddenly reduced to 500 a day, and that's what we've been having since. So there was even 1 or 2 days when no one came or left from New Zealand, which was an historic event for this country. The other components was high volume testing and contact tracing. This is going from no testing capacity in early March up to being able to test 25,000 people a day, which was a high volume for New Zealand, a country our size of 5 million people. So again, I'm not expecting you can see all the details here, but this is to illustrate the 5-level alert system in New Zealand, which escalates right up to level 3 and 4, which are the equivalent of a stay-at-home order. So that is requiring people to stay at home unless they have a reason to go out, either they're an essential worker or they have to get food or medical care. So this was showing the stringency of these controls in New Zealand. And this is using the Oxford Stringency Index. And New Zealand peaked for this 5-week period at the highest level of stringency that has been recorded on that index. And then we moved down for 2 weeks to a lower level, and then we returned to quite a low level of stringency quite quickly compared with, say, Australia. The effect of this was that the entire population essentially stayed at home for 7 weeks, and that extinguished the transmission in New Zealand. So we emerged into a virus-free country. This is showing some images from New Zealand at that time. This is showing the main highway into our capital city at what would have been rush hour normally. And this is a paper we published in the New England Journal of Medicine 2 months ago to show the epidemic curve in New Zealand. And this is cases that had traveled from overseas, and this is local cases. And it's showing how we were switching from imported disease to local transmission and we were starting on that exponential part of our curve. And these lines here are showing the different alert levels, and this is the 5-week period here when, also 7-week period in total, when we had a stay-at-home order, and that, as I was saying, largely extinguished transmission in New Zealand. So what is the overall impact of the strategy in New Zealand? This is showing the deaths per million, and New Zealand has the lowest case fatality or mortality rate from COVID-19 in the OECD. It's currently at 5 per million. One of the other consequences in New Zealand we were interested in was looking at total mortality, because even though we had we've only had 25 deaths from COVID-19, we were concerned about adverse effects from the lockdown, and for example, mental health effects, and potential increase in suicide, and domestic violence, and a number of other potential consequences. Mortality data was quite reassuring. It showed no rise in mortality during the lockdown period. There was no increase in suicide rates. And we're constantly updating the data, but at this stage in the year, after 9 months, we've seen a 5% decline in mortality. This is what we were seeing early on, has persisted for the year to date. Influenza has virtually vanished in New Zealand, and our excess winter mortality has basically disappeared. And by the end of the year, we would expect to have 1,500 fewer deaths in New Zealand, which is about 5% of the normal deaths we get in a year. So that's almost certainly been driven by a decline in respiratory infections. So I haven't got very much on the economic effects of the New Zealand response. We certainly had an economic, major economic contraction, and we are in recession, but the employment levels have remained high in New Zealand, partly because of a wages subsidy. But we are expecting the economy to return to fairly normal functioning quite quickly. So this is, again, an extremely busy slide here. I'm not expecting you to see the details, but this is trying to look at the difference between countries pursuing a suppression approach, which is most of Europe and North America, and countries in East Asia and Australia and New Zealand who are pursuing largely an elimination approach. And this is looking here at mortality rates per million, as you'd expect, as I showed a moment ago, typically around 500 per million. Whereas countries pursuing an elimination approach, particularly China, Japan, South Korea, Taiwan, Australia, and New Zealand, are really experiencing much lower mortality. But the other thing on this, and again, it's a very crude indicator, this is the GDP change in the second quarter. And again, most of these countries are experiencing a much smaller decline in GDP following successful elimination. So what these data, and these are sort of early indicators, are suggesting is that eliminating transmission, or trying to eliminate, is actually very good for public health, but also the health of economies. So one thing, one component of the elimination strategy that I haven't mentioned is this area of resurgence planning or outbreak planning. And New Zealand went for basically 102 days with no local transmission. These are just imported cases who are held in quarantine and are only released after 2 weeks and after being tested twice. So they are no longer infected when they're released from those facilities. But then we suddenly saw an outbreak occur in mid-August. That outbreak has now been brought under control with lots of testing and contact tracing, but also using a very targeted, minor, less intense lockdown for just 2 weeks. And so this illustrated to us that part of the elimination approach is being able to manage these outbreaks when they occur. And most countries pursuing elimination have had setbacks in the form of outbreaks and brought these under control. So the key lessons from the elimination strategy in New Zealand are that these are areas that we are proposing for future, is to get is to shift to being more strategic, and that's this high-level science council and more research and development, trying to improve the quality of science information around us. And we've asked for an official inquiry after the October election, which we have just actually had our election, it actually got deferred, and also that we set up a specialist national health agency in New Zealand. So one of the other lessons from the elimination approach is to think more about what other diseases can this be applied to. And I think one of the major ideas from the successful use of elimination is that we've got a tool now that we could potentially apply to new emerging diseases, disease X, in this case COVID-19, but to other new emerging diseases, but also potentially to pandemic influenza. We know that we've already eradicated diseases with an elimination approach. There's global eradication underway for some diseases. There are regional elimination approaches and other diseases where we're gradually moving towards elimination. And a number of these diseases, we have test and trace methods that would support an elimination approach. So what are some of the other key lessons? Well, I think the combination of effective science and good political leadership is critical. Jacinda Ardern and her Labour government were just re-elected on Saturday, so just 2 days ago, and for another 3-year term. And I think one of the reasons she won a landslide victory in the election was because of the government's very effective management of this pandemic. So I think there's some institutional lessons that eliminating this disease has benefits for health and the economy. It does. We do need effective risk assessment and strategic decision-making in public health crises. I think equity and partnerships with communities are very important. There's a need to strengthen public health infrastructure. And we also think there's a need to reform global health agencies like the World Health Organization. Among other things, they need a lot more resources to support their capacity to coordinate global responses. But one of the other biggest messages, I think, from this is this opportunity for a broad reset and increasing this focus on managing major global health threats on the horizon. And in many ways, COVID-19 is, while it is a global tragedy and an emergency, it is far less dangerous in many ways than some of the other global health threats on the horizon. And just to summarize, I think we can see with COVID-19 all of these impacts, inequalities, uncertainty, questions around controllability and panic and outrage. New Zealand chose an elimination approach to protect health and the economy, and that seems to have performed better than the alternatives. We think it's an opportunity to strengthen public health capacity, and we hope also an opportunity for a major reset towards an equitable and sustainable society. And I just want to acknowledge my many collaborators, particularly two of my major co-researchers here, and some of the partnerships we're working with. And this is probably doesn't mean very much to people overseas, but New Zealand had a flag debate, and this was one of our favourites of a Kiwi with a laser coming out its eye and its ability to zap coronavirus. And this flag, I should say, was never adopted, but it has had its uses on occasions. Thank you very much.
Thank you very much, Professor Baker, for this very interesting presentation. I think it's really great to start our conference with such a powerful story, a success story that combines very solid foundations in public health, but also very clear political leadership and strategies. There are a few questions in your direction, and the first one is countries are increasingly conducting surveys to take the temperature of the population about how they're tolerating various public health measures and lockdowns of various severity. Did you do any of these in New Zealand, and do you have an insight into the acceptance of public health measures, especially going forward?
Yes. We've had a number of longitudinal surveys to gauge the impact, particularly of the pandemic response, because of course it's very extreme. I mean, not in my working life. I think it hasn't happened before that we've required the entire population to stay at home for a prolonged period. But the measure was so effectively communicated, it was very highly accepted and highly supported by the public. We were very concerned about mental health consequences, and some people did find it a very difficult period. But a surprisingly large majority of people found the experience of being in a lockdown actually quite worthwhile, and it gave them a chance to look at a different way of living. And almost quite paradoxically, people on average liked it. But there were some people where it was extremely difficult. And we are concerned about the deferral of other important services, particularly primary health care, that happened over that time.
Yes, very good. And I think that leads us maybe closer to our next question, which focuses on the role of contact tracing and the need to create surge capacity in public health workforce and primary health workforce during the pandemic to support contact tracing, quarantine, and isolation measures. What was your strategy in New Zealand regarding this? Were you able to attract a large number of people rapidly to work in public health and primary health care to contribute to these funds?
Yes, well, the primary healthcare system in New Zealand was reasonably robust anyway, and it coped with setting up community-based assessment clinics that were with some support from the Army, who provided a lot of the logistics. And these were often tents and so on that were set up near hospitals and near medical clinics, but also sometimes in places that were near populations that might have had trouble accessing care. So a lot of nursing staff, medical staff came back from retirement to help out. So that capacity worked very well. One of the interesting things was that the hospitals were basically cleared out of all elective surgery and other any avoidable work, and they were almost empty for this whole period because the expected pandemic didn't happen. And so our intensive care units, which were actually, we don't have a large capacity for our population, were largely empty over this whole period. So that was one aspect. One workforce that did need to be hugely supplemented with contact tracing staff because we just did not have that capacity. I mean, that was extremely weak at the beginning of the pandemic because those workers really only had a limited number of diseases they had to follow up on, things like tuberculosis and meningococcal disease and a few others. So that workforce was tiny and that had to be built up very rapidly.
Very good. Thank you very much. And that leads us to our final question before we let you go. You mentioned that all-cause mortality did not increase and potentially decline. You mentioned that seasonal influenza was virtually very little during this period that could have been the cause. But were there other causes that you anticipate contributed to this picture? For example, probably not a big issue in New Zealand, but other countries, road traffic accidents, are declining very significantly. On the other hand, in other countries, we're seeing increasing number of cardiovascular events that contribute to an increase in mortality. Maybe if you could speak a little bit about unpacking what's happening to the delivery of essential health services during this time in New Zealand. Did you experience any disruptions? If not, how did you ensure that there were no disruptions? That would be also very interesting related to that figure. Thank you.
Yes, well, look, we are very concerned about the disruption of normal care, particularly preventive care in the primary care setting. And, you know, cancer screening rates have dropped, and obviously visits to medical practitioners, primary care practitioners over this period for non-essential care dropped. So that will have long-term negative effects. But all-cause mortality was we won't have the fine-grained cause-specific mortality for quite a long time. That's quite delayed. But all-cause mortality dropped markedly, and certainly road traffic crashes dropped during the lockdown because there was very little activity on the roads, but have returned to normal rates. But you know, the year as a whole will finish with 5% lower mortality. It's been very consistent, and I think by far the biggest driver will be this drop of respiratory infections.
Thank you very much. I'd like to thank you for your presentation and your excellent answers to the questions. And with that, I'd like to thank you very much. With that, I'd like to go to our next presentation. We're going to hear from the experience of Japan. And I'd like to introduce our next speaker, Professor Норио Омагари, who is Director of Disease Control and Prevention Center at the National Center for Global Health and Medicine.
Okay, thank you very much for kind introduction. My name is Норио Омагари from Disease Control and Prevention Center at National Center for Global Health and Medicine, and which is actually located in Tokyo, Japan. First of all, I really thank you all who are involved in this seminar and the symposium, and for letting me have a chance to talk about the situation of COVID-19 in our country. So, okay, let me start my presentation. Let me share my PowerPoint slide with you. Alrighty, can you see my slide? Is there any problem? Okay, sounds good. So my talk is about the Japan's response to COVID-19 from an international perspective. So let me start the story which happened back in January. So this is a picture taken in a TV show, and actually this picture is showing aircraft just came back from the Wuhan, China. And in the late January, the Japanese government planned the evacuation of the Japanese and the relatives from the Wuhan back to Japan for the evacuation for the COVID-19, which was quite prevalent at that time in Wuhan. And our center, National Center for Global Health and Medicine, was actually the screening center for the evacuee from Wuhan. We have accommodated the evacuee for 6 times from the Wuhan, and the total number of the evacuee was over 600. And for all of the passengers, we did a screening by PCR testing, and also we did a screening by symptoms of them. And we found that around 2% of the evacuee were PCR positive. I mean, positive for the COVID-19 by PCR. So although we were experiencing scattered cases, imported cases of COVID-19 back in January, but to our country, I'd like to say that this is the first time for us, our country, to face the threat of the COVID-19 for the first time. So now I can show you this picture because that was secret in the last 8 months, but I can show you right now. So this is the picture. Left side picture is a picture taken in at the site of the screening. They are getting a history from the patient, and also they are getting a sample from the patient, of a sample of PCR from the patient. And the right side one is the media. They had a very hard time for catching the picture of this evacuee, and the bus which were Chinese evacuees because it was so cold in the late January in Japan, even in Japan. And next big event, big incident, accident, I have to say, or could be disaster, I have to say it the having a very big cruise ship from other part of the world into Yokohama Bay. So this big cruise ship, Diamond Princess, had thousands of passengers in there. And actually there was a cluster of COVID-19 in late January inside of this Diamond Princess. And then this Diamond Princess came over to Yokohama Bay for the quarantine. And actually, to our country, this was the first time for us to handle with this huge outbreak. And also, this is the first time for the Japanese government to handle a major, huge outbreak of infectious diseases in the cruise ship. So actually, the quarantine and medical help and medically help was quite difficult during the time of the to cope with this issue of a COVID-19 cluster in the Diamond Princess. Actually, in the very beginning, in the early February, actually we had more than 700 PCR positive cases of COVID-19 at the same time, almost at the same time, and it was quite hard to have, to prepare for the bed for all the passengers coming down from this Diamond Princess with PCR positivity. So the local government and also central government of Japan had a very hard time to accommodate those PCR positive patients. But anyhow, they did it. And actually, our hospital is far apart, located from the Yokohama Bay. However, more than I remember more than 20 patients were transferred to our patient, and of that there were more than a couple of quite severe COVID-19 patients who necessitated mechanical ventilation and also ECMO, extracorporeal membranous oxygenation. But somehow we have cured about it. So through this experience of having a patient of a COVID-19 from the Diamond Princess, we learned that what is the fact, what is the reality of COVID-19, especially the reality of the patients with severe COVID-19. And we really had to think about what is the surge capacity. How we can have surge capacity to cope with this large number of COVID-19 patients in terms of the public health response, in terms of the transfer of the patient, and also in terms of the medical care. So this lesson was quite instructive to our country. So this is our situation. This is the current incidence of COVID-19 cases in Japan, 2020. So in April, from March to April this year, we had a big surge of incidence of COVID-19 all over Japan. And actually, in the late of March 25, the governor of Tokyo declared that we might need a lockdown. Actually, based on the Japanese law, the Japanese infectious diseases law or special law for the to cope with novel pandemic influenza, logically, we cannot do the lockdown. However, she dare said it. But it was a quite strong message to the people, the residents of the Tokyo metropolitan area. So actually, they changed the behavior. They didn't go out to the any part of the place, any part, and they stayed inside, stayed home. And we really believe that this kind of behavior on the side of the public really helped to decrease the incidence of COVID-19 in late March and early April. And there was a big discussion among the public. And as we had a quite hard time for the capacity of a healthcare facility to accommodate patients with COVID-19, there was a discussion about the stating state of emergency inside of Japan. But finally, to help and to protect healthcare facility and healthcare system, the government of Japan declared state of emergency on April 7th. then the incidence of COVID-19 decreased. And actually, the government terminated the state of emergency on May 25th. Afterwards, we had a relatively calm time, and actually the government was relaxing the policies they did to contain this COVID-19. But then we began to experience the research of cases of COVID-19 in early July, and it was peaked in the early August. But unfortunately, the incidence of COVID-19 declined. However, from the September to up to now, in the mid-October, we don't see the remarkable decrease in the incidence of COVID-19. It appears to us it's relatively stable. It don't go up sharply, but it won't go down sharply. It appears just stable. So some people here in Japan says that, we might be in the dancing state. The street about hammer and dance. So some people are arguing that we may be, in the stage of the dancing. However, there is another discussion that, we have to really think about, we have to tolerate this level of new incidence of COVID-19 in Japan. I believe that more than half of the people here in Japan hopes that we have a smaller, much lower incidence of COVID-19 here in our country, because everybody knows that if we have significant number of incidence COVID-19, that will lead to significant number of severe cases of COVID-19 and could lead to some death. Talking about the mortality of COVID-19, I wrote here that it's incidence actually, but this is the mortality. Talking about the COVID-19 cases, mortality of COVID-19 in Japan, total, as of today, we had 1,649 people died because of the COVID-19. Most of them are elderly, and a significant part of them had one or more comorbidities, including heart disease, COPD, or cancer, diabetes, something like that. So compared to the international numbers, the numbers from other parts of the world, the number of 1,600 appears to be relatively small. However, it's significantly big still. So we, the Japanese people and the Japanese experts and the Japanese government, they are thinking about how we can stop the death by the COVID-19. And I believe that that will probably can be achieved by decreasing the number of the severe cases of COVID-19. To do that, we are now discussing how we can do that. So this is the age distribution of the patient in terms of the age distribution of COVID-19 in our country. The left side graph shows just a simple age distribution of total cases of COVID-19 in our country. As the numbers in other countries, we have a peak in the incidence of COVID-19 between the 20s and 30s. Actually, in the early, in the March and April, we had a peak in the incidence of COVID-19 in the 40s and 50s. But we believe that that is because of the criteria for the PCR. At that time, we were undergoing PCR testing for patients who had pneumonia, not patients who had the upper respiratory infection. So by doing that, probably we are catching more severe patients with COVID-19. So that can explain why we had a deviation we had a top in the peak of the incidence of COVID-19 in this spring. However, now we have a peak in the incidence in the 20s and 30s. On the right side panel, I'm showing the graph that is showing the total number of mortality stratified by age group. As is similar in other countries, we have a peak in the incidence of the mortality of COVID-19 or at the age of 70 or higher. So basically, the elder is a major victim by the COVID-19 in our country, and I think that is quite similar. That is quite similar in other parts of the world. So now the point of discussion in terms of infection prevention control in our country is how to protect this age group. I mean, age over 60 or more or higher from catching COVID-19. By doing that, we believe we can decrease the number of severe cases of COVID-19, or we can decrease the number of the mortality by COVID-19. I just a little bit go into the detail of demographics of COVID-19 cases in our country. In our country, in the late March, we established a registry database of all inpatients of COVID-19 in our country. By doing that, we believe that we have more idea of COVID-19 in terms of their clinical characteristics. And also, we thought that by doing that, we can see the trend of the change of a clinical picture of COVID-19. So this is the actually comorbidities and the severity of COVID-19 in our the cohort of the registry. So we looked into the prevalence of congestive heart failure, peripheral vascular diseases, cerebral vascular accidents, COPD, and hypertension, hyperlipidemia, and diabetes, obesity as well. So, and actually, this is a case of all, and this is a case of no oxygen, required no oxygen. This is a patient who required oxygen. This is a patient who needed intubation, I mean mechanical ventilation. So it appears that if the more severe patient has more higher prevalence of comorbidities, including the congestive heart failure and the diabetes. So it appears that if the patient has significant comorbidity like heart diseases or cerebral vascular diseases, they are at high risk for the developing severe COVID-19. But what we learned is the general prevalence of this kind of comorbidity, including diabetes and obesity, is much lower compared to the number of UK and also US. And through the study by this registry study, we learned that the mortality of the inpatient in Japan is much lower to the number of the inpatient in UK and US. So I think more than a couple of hypotheses can be drawn for this study, the result of the study, but we believe that the low incidence, low prevalence of comorbidity might explain, at least partly, the lower mortality rate of COVID-19 in our country compared to US and UK. So this is the severity of illness on admission of hospitalized cases in our country. The left side one is the cases of cases admitted before June 5. We might want to say this is the first wave. And the right side one shows the data of the cases admitted on or after June 6. So we might want to call this is as a second wave. And we did see the severity of illness that is stratified age group. And actually, red bar shows the seriously ill patient on admission. And we defined that the serious, critically ill on admission is the oxygen administration and ventilator management, SpO2 of 94% or less, or respiratory rate of 24 breaths per minute or more. So we have relatively mild, not strict criteria for the severe infection of COVID-19. But anyway, so that one shows the seriously ill patient on admission. So let's go into the age of 70 or more. And at that point, in the first wave, 48% of the case of a patient, elderly patient, more over 70 were seriously ill. But actually, on the second wave, talking about patients 70, age of 70 or higher, actually the rate of seriously ill patient on admission was 30.4.6. So it decreased. So it appears that compared to the first wave, in the second wave, basically we had a less severe patient of COVID-19 as an inpatient. And that phenomenon can be also seen when we stratify the cases into the age group. And a similar trend was also seen in the proportion of post-hospitalization deaths. Post-hospitalization mortality in hospital cases. We divided the cases into two categories. The left side one is mild, moderate on admission. The left side is a serious illness on admission. And we compared these cases before and after June 5. Compared between the cases of first wave and second wave. So to make a sound comparison, please look into the data of cases of serious illness. And to make a more sound comparison, please just get into the elderly people. The people, the year 50 is not elderly, but just for the sound comparison, let's go look into the detail of the patient 50 or older. And basically, compared to the first wave, on the second wave, the mortality of the patient has decreased, even though we stratify those data by age group. So it appears that, even after this stratification by severity and the age group, we will still see the tendency of decreasing mortality rate in the cases of severe COVID-19. So something might be working. So we have to say that something might be working or something might be doing something. In terms of the decreasing the mortality of COVID-19. That could be improved clinical care, or that could be earlier diagnosis, or that could be a change of the the gene of genetic background of the virus itself, or it could be the change of the population in terms of the immunity of the COVID-19. But we don't know for sure. But anyway, it's decreasing. So changing in clinical care is also evident. We now see that the time from the onset of the symptoms to diagnosis of the COVID-19 has significantly decreased in Japan. Actually, this is the data of time from onset of symptoms to diagnosis in Japan. The silver one line shows the data of actually Tokyo metropolitan area, and the blue one shows the average number of the Japan itself. So in the very beginning, in the early February, we had a very hard time to have the patient to take the test. In Tokyo, the average days was 14.5 days, quite long. But because of the work of the government, local government, and healthcare facilities to expand the capacity for PCR testing, the duration decreased significantly. And in the end of June, it decreased down to 5.08. But compared to the number coming from New Zealand, we have to really decrease this number less than 3. I'd like to show you some typical case of severe COVID-19, whom we took care in Japan. So actually, this is the 63 years old male patient who came over from U.S. He actually visited Japan by a Diamond Princess. So he was a passenger of the Diamond Princess. One day, he developed symptoms of upper respiratory infection, and on the next day, he had a test for the influenza, which came back negative. On the third day, he had a PCR for COVID-19, and on the day 6, which came back positive. And on the day 7 of symptom of illness, he was transferred to our hospital because of the pneumonia by COVID-19. And actually, his clinical course was quite stormy. In 2 or 3 days, his respiratory status deteriorated. And actually, on day 10, he necessitated mechanical ventilation. However, as his respiratory status got quite rapidly and he cannot tolerate only on the mechanical ventilation, we introduced extracorporeal membranous oxygenation, ECMO, for this patient. And actually, it was quite a difficult time to take care of this patient because we, the physicians, didn't know what happens in the coming clinical course of the patient. We didn't know how long it takes for this patient to recover. So we just continued the ECMO and we just continued mechanical ventilation. We introduced, investigational drug, which was actually proved to be remdesivir later on. And we also use steroid empirically, although we didn't have a result of a mega study, randomized control study by UK at that point. But fortunately, almost 3 weeks after the intubation, his respiratory status got better quite rapidly, and we put the ECMO off. And 1 week after that, we actually put the mechanical ventilation off from this patient. Although it took 3 months for this patient to recover enough to go back to the home, because of the long time for rehab, it took time. But finally, he got better, and he, went back to the U.S. Actually, he had his hometown is Colorado, and he sent me more than a couple of pictures to show me that he's doing very okay. So we're quite happy about it. But at the same time, we have to really say that having a patient with severe COVID-19 is quite tough as a healthcare personnel. And that also would be a quite big burden on the side of healthcare facility and also healthcare system. So by learning, through taking care of, through the experience to take care of this patient, we really learned that sound clinical judgment and improving clinical care is quite important. And at the same time, we really learned that we have to decrease the incidence of COVID-19 as a whole to decrease the case of severe COVID-19 and also could prevent the death. So that's why I still have to say that public health intervention to decrease the incidence of COVID-19 is critically important to help, to save and healthcare system in our country and also other parts of the world as well. So let me talk about a little bit about the treatment of COVID-19 because I'm a clinician and I'm also involved in the research and development of diagnostics and the therapeutics of COVID-19. When I talk about the treatment of COVID-19, I divide the clinical status of the COVID-19 into 3. That is a mild one, like an upper respiratory infection. The second one is moderate one. That includes a patient who needs pneumonia and who needs oxygenation. And also the third, the severe one as well, who probably needs mechanical ventilation. And on the case of moderate to severe COVID-19, now we have sort of standard of care. In terms of antivirals, remdesivir has shown that significant decrease from the time of recovery compared to the placebo by randomized controlled trial. I know that there was a discussion. There was a preprint paper that came out from the WHO last week, actually. But we have to seriously think. I don't get into the detail of the assessment of this new study, but it appears to me that the paper from the WHO shows a sort of real-world data. But it's quite difficult to make a comparison of a sound randomized controlled trial versus real-world data. So we have to really look into the detail of it, and we have to really think about what is a productive way to utilize both of the results into better clinical practice of the COVID-19. Anyway, so talking about other antivirals, more than many pharmaceutical companies are now going on the research and development of other antivirals. And also, we have a hope about utilizing convalescent plasma and also specific antibodies to cope with COVID-19. And talking about treatment of COVID-19, anti-inflammatory drugs play a major role because in some fraction of the patient with COVID-19, they become very severe status because of the dysregulation of the immune system. To fix that, we need immunomodulators or otherwise, in other words, anti-inflammatory drugs. At this point, we know that dexamethasone has shown a decrease in the mortality rate by the randomized controlled trial by UK. So in many parts of the world, they are now utilizing dexamethasone as a treatment as an inflammatory drug for patients with severe COVID-19. And also, there are other candidate anti-inflammatory drugs which is now under a trial. trial. And talking about anticoagulation, now we know that there are some significant percentage of the patients, especially in the severe, moderate to severe COVID-19, has some sort of the blood coagulopathy. I mean, like elevated D dimers or something like that. And some fraction of the patient might experience big blood thrombus in the major vessels. So to fix that, we have to think about utilizing anticoagulation. And from that point also, more than a couple of the trials are now undergoing to show the effectiveness of this kind of intervention, I mean, the anticoagulation. So this is the general picture of the treatment at this point. So talking about the treatment of COVID-19, I have to say about the burden of patients taking care of the patient with COVID-19 in healthcare facility. And actually, in the early April, we had a very hard time. And actually, after the statement of state of emergency declaration by a Japanese government, we had a peak in the incidence of the inpatient in a hospital. In a hospital, I mean, our NCGM, the NCGM has more than 700 beds. But on the peak of the incidence of COVID-19, we had 47 inpatients in the NCGM. And at that point, 8 patients were intubated and on mechanical ventilation, and 2 patients were on the ECMO. So that time was the most hardest time for us healthcare workers at NCGM. But unfortunately, gradually, the number of total inpatients of COVID-19 decreased gradually. And when we faced with the second case, we had 30 patients at the peak of a second wave of COVID-19. However, at that point, well, we had much smaller number of the severe case of COVID-19. We experienced one patient who needed care in the intensive care unit, and that was the only single patient who needed intensive care. So on the ground, we healthcare workers feel that on the second wave, well, we didn't see the severe patient compared to the first wave. So something is changing. And the same similar thing is happening in the other parts of the world as well. Okay, now I have almost 20 minutes. So in the last amount of time, I'd like to talk about some issues of infection prevention control. Now we know that this COVID-19 will create a cluster, which is a different, and in that sense, the COVID-19 is quite different from influenza because we don't experience big cluster in the influenza. We usually don't know where we catch, the influenza. However, we now know by the epidemiological study that the significant number of the cases of COVID-19 is created in the cluster. And when we have a cluster buster team in the Ministry of Health, Labor and Welfare, they found by looking into the characteristics of the case of COVID-19, they saw that almost 80% of the case does not transmit COVID-19 to anybody. It just stops. However, talking about less than 20 patients, the situation is quite different. They transmit a patient to the more than a couple of patients. For example, this is the horizontal line shows the number of the patients who was infected from single index patient. Here we see one cluster which caused that one patient transmitted the COVID-19 to 9 patients. Here we see another cluster that one index case transmitted COVID-19 to 12 patients. So we now know that the large amount of the patient can be not created. It can happen from the cluster, mostly from the cluster. So that means that the strategy to battle with the cluster is quite important. And by looking into the detail of epidemiological data of the cases of the cluster buster team found that we have 3 principles in terms of the high-risk places of COVID-19. And that is closed spaces and crowded places and close contact settings, and maybe chatting or making a loud voice inside of it. So the cluster buster team drew this quite simple principle from the epidemiological study, and the Japanese government actually utilized it to make risk communication to the public in terms of to prepare the general public to avoid high-risk places in their daily life. So that is the 3C. So now we, as experts from Japan, we feel quite happy that the WHO is now also utilizing this concept of 3Cs. And also last week, I had a news from the UK that the Professor Jonathan Bantam is a very big guy in terms of infection prevention control in the UK government, and he raised that the principle, the idea of 3Cs. And he called upon the public in UK to utilize this principle as a self-prevention from the COVID-19. So I, as an expert from Japan, I myself feel that having this kind of a quite simple principle is quite important in terms of the risk communication to the general public. By knowing this kind of simple principle, the people can do what they can do in terms of the prevention of COVID-19 in their daily life. That is quite important. By doing that, we believe we can controlling the incidence of COVID-19 somehow by introducing a quite severe lockdown. In other parts of the society, they are making every effort to decrease the incidence of COVID-19. Actually, I'm in charge of the organizing infection prevention control in the theater or traditional theater in Japan. So I took this is a picture taken in that old theater. This is a picture before the opening of the play, and now you can see the social distance between the guests of this play, and they are, and these rules are quite, strictly, obeyed by the people in Japan. And actually, their actors, they have to make a very loud voice. So to prevent the droplets and the micro droplets to distract, they are wearing a mask, very special mask, nice mask. And the government is calling for the congestion-free commuting. This is quite important. And actually, this is one picture taken in the subway in Japan. And you can now see the subway. They opened the subway company opened the door halfway, and they also actually did a test. They did some sort of experiment for the air ventilation inside of this. Inside of this subway, and they found that if a standard commute train speed about 70 kilometers per hour is driven with the windows open by 10 centimeters, the air inside will be changed in about 5 to 6 minutes, quite rapid. So it means that the air will be exchanged 12 times per month, 12 times per hour, which is also equivalent to the high quality ventilation room in the hospital. So this is the evidence drawn by the experiment. By doing this kind of a simple experiment, all the business player is having very hard time, and they are working very hard to realize quite safe places and quite safe situations for their guests and for their workers in terms of the prevention of COVID-19. And lastly, I'd like to call upon the importance of the universal masking in this era of COVID-19. I know that the people, especially people in the East Asia, like masking, and I also know that in other parts of the world, it might look funny, but now based on the more than couple of the results coming from the other part of the world, they know. Everybody now knows that the masking quite variable. It's quite effective in terms of the decreasing the incidence of the healthcare workers and the patients in the hospital. So this is one perspective paper coming from New England Journal, and they are calling upon the importance of universal masking in hospital in the COVID-19 era. So we have to think that we have to change the idea of masking. Up to now, we believe that by wearing a mask, we can prevent us from catching the COVID-19. That is true, actually, partly. That is true, at least partly. However, the idea of universal masking is a little bit different. Universal masking is the wearing a mask even though you are asymptomatic, but to prevent the disperse of a droplet or micro droplet by making a noise or by making a voice or having a very hard breath, to prevent the transmission of those particles to others for the prevention of the COVID-19. This is a dramatic change of the idea of masking. So I think this is quite important. And in Japan now we are really thinking about importance and also the core principle of universal masking into the young generations, because they actually act as a transmitter of COVID-19. But we really wanted to know that by wearing a mask, they can decrease the likelihood for them to transmit COVID-19 without, harming their usual activity. I'd like them to enjoy their daily life, but I'd like also want them to prevent the transmission of COVID-19 to the high-risk, generation like elders. So this communication is again quite important in our country. Okay, so thank you. So this is the end of my slide, and my last time is open to discussion, I believe. Thank you so much.
Professor Omagari, many thanks for your very rich presentation. You covered a lot of ground. You talked about effective public health strategies, but you also addressed some important clinical strategies to mitigate the impact of the pandemic. Let me now turn to Dr. Peribayev and ask if there are any questions that our participants would like to ask.
Thank you, Madam Yakab. Thank you, Professor Омагари. Actually, you touched upon the issue from many points, demonstrating eloquently various procedures and tactics regarding the fight in epidemics. We have several questions. How Japan, which did not introduce mass testing or strict restrictions, managed to fight the infection earlier than other countries? And the second part of this question is regarding the Japanese readiness to the second wave of coronavirus infection. Thank you.
Thank you. Okay, talking about the first question, actually, we cannot do the lockdown in our country because we don't have a law to allow that. However, the government and the local governors made a strong voice. And actually, they called upon the general public to stay at home as possible as they can. And also, in some part of Japan, the governor, asked the industries and the shop owners to close shops after 10 p.m. or 8 p.m. And actually, the general public and the shop owners followed that call from the government and the governors of the local governors. It might strange that the general public to follow this kind of the call from the government, but it actually happened. So some people say that there is a quite strong peer pressure among Japanese society, society in Japan. Actually, I think that is also true. However, I feel that there is some sort of principle and atmosphere in the society of Japan, and we share some sort of one purpose to decrease the incidence of COVID-19. So in that sense, the call from the government worked. And your second question is, could you say that again, please?
Yes, second question regarding whether Japan is ready for the second wave of COVID.
I see. Well, the thing is, talking about before the phase of the second wave, the government was relaxing the policies based on their call gradually, very gradually. But at the same time, they called upon the incidence of the quite important aspect of COVID, the avoiding 3C, which I introduced. So in other words, the government of Japan utilized the tactics to sort of pinpoint tactics to mitigate the transmission of COVID-19. And the second thing is, I think that healthcare system has been much improved compared to the first wave and in the second wave. In the first wave, I'd like to say that the healthcare system were not prepared for accommodating with a large number of the patients with COVID-19. But on the second wave, the local government and all the healthcare facilities worked very hard to establish a system. So actually, there was not any panic or concern in terms of the operation of the healthcare facilities. I think that also helped in terms of stabilize the mood and atmosphere of society itself. Over.
Thank you, Professor, for your answers. And my third question, on behalf of our audience, what do you think, when we will return to a normal life, and what are the perspectives of Olympic Games in Tokyo in 2021 summer? What will be the safest formats for having these Olympic Games, without spectators, with spectators, or it will be just cancelled again?
Sure. I honestly, but in my sense, we feel in Japan, we feel that we are rapidly coming back from the normal. I thought it took my 5 years, but in a couple of months, we see that our life is coming back from the normal quite rapidly, and that is probably because we know that what is the critical point of the prevention of COVID-19, that is 3C. So if it works, we think that our daily life will get back to normal gradually, other like a months or so in the sort of the time span. So I hope that we will go back to our normal status in 1 year, 2 years. So talking about the Olympic Games, how safe we can do that, it depends on the situation of the COVID-19 at that point, significant point. But if we continue to this kind of improve in the in terms of the prevention of the COVID-19 and the improvement in the the healthcare system in our country and improving the atmosphere, the mood of the Japanese public here in Japan, I myself believe that we can do the Olympic Games in the next summer. However, to do that, we have to introduce a strict system to pursue the import of the cases of COVID-19. I'm sorry for the passengers from other parts of the world. However, I myself, as one expert, I believe that we have to do some sort of the pursuit of the passengers coming other parts of the world, just in case they develop the COVID-19. And we may have to decrease the number of the audience on the stadiums of the Olympic Games, but which we really think about it, because we may not have to decrease the number of the audience on the stadium, because because the number of the audience may not be a major player in terms of the transmission of COVID-19. So anyhow, by introducing every method we can do, I believe we can do Olympic Games. It appears to be a different one compared to the usual Olympic Games, but we can see, I hope we can see some sort of the new normal Olympics in the coming summer. Thank you.
My slide, we're talking about primary healthcare and 19 thoughts on PHC. While hearing presentations from New Zealand and Japan, I have quite mixed feelings. On one hand, I'm very proud of my colleagues who managed to control the situation as professionals in their respective countries. Unfortunately, our own experience has some difficulty approach. One doctor, Омагари, says that 1,600, more than 1,600 deaths comparing versus the total number of Japan population is not such a big loss, but unfortunately we do not know our statistics clearly, and we can say only approximately from 20 to 40,000 people who died of COVID. We could refer to people who were tested through PCR tests as COVID positive. We could also refer to this number of casualties to those who had no proven laboratory tests on COVID, and those who did not receive medical assistance and died without medical assistance, suspectively because of COVID-19. And now I would like to mention Professor Khamsin. He is a professor of urology of Kazakh Russian University. According to him, what had happened, we as a country lost the virus from the point of ideology. The public trust were lost to the medical facilities. Our foundation, our board made a survey among the public on the peak of COVID cases in Kazakhstan from mid-June to mid-July, with more than 9,000 respondents, and two-thirds of them reported that they lost confidence to medical practitioners and medical institutions, and they said that they did not refer to primary healthcare professionals. Instead, they either not referred to medical assistants or just referred to tertiary medical care, to medical specialists. And the main problem here, as Gildi Sharmanov said, there was a mistrust between the government and the public and medical institutions and COVID epidemics, and especially in terms of assistance to the population. The black swan is a symbol of unpredictability. This refers to a rare and unpredictable events which had a big impact, although COVID-19 was not a black swan from my perspective, but our response on behalf and what had happened to our system, this was the black swan. Indeed, I am talking about unpredictable response on behalf of our medical institutions. The pandemic revealed those problems which we had in the system even before coronavirus. Let us see. Kazakhstan is on the 91st position in the world in terms of per capita spending on medical assistance between Paraguay and New Guinea, set up by the government on behalf or to the medical institutions is according to OECD standards. And our experience in this medical system is thoroughly responsible for health status of
laws and regulations, whereas primary health care is mentioned in more fragile before the pandemics, because they were not permitted. Talking about primary health care, 90,000 of them are primary health care. They're allocated inside of those 70%, 70. That means that 37% time we have 27, not talking about industry protocols of diagnosis, did not have a big background and have to concentrate on primary health care. That wasn't people allocated to our facility. We were growing and developing as a network of changes of rules and regulations. And in this situation, my skin was to be at stake. My reputation was at stake. So we were always eating that was prepared by others. So that was the paradigm that we had to exist. 27 roadmaps, 65 rules and regulations which are constantly changing. So how could we survive? And returning to black swan, to unpredictability. According to some faith, we were the first to bury the first patient who had confirmed coronavirus diagnosis, and she was just 10 years older than me, the patient Imanbayeva. And we understood that no one knows anything. There were no rules or regulations, no algorithms specific to the situation. So we were left alone with the corpse of our patient. And I will tell about this story separately. But at that time, I understood that at such difficult time, the primary health care stops to be only medical, but it becomes a social buffer between the society and the government, society and the state, society and politicians, and the people in white robes, the doctors, become and they stand at the frontier of this struggle, whether it's pandemics or other disasters. So while developing, we were ideologists and developing the concept doctor near your house. So we were developing together with the city infrastructure. 9 years ago, nobody was thinking about it, and people were thinking, what kind of small organization, what are they doing? That was very interesting, and throughout that time we have grown tremendously. And for the last 2 years of my personal professional task was to remove that Russian letter near and make a new format of being a doctor at home. And that was an ideology which has faced us during pandemic. And the small things, they create opportunity for large things. We were gradually approaching this step by step, but the challenges that we had globally in January, that they made it necessary paradigm for all of us. I was writing about those home stationaries or daycare, and that was in order to provide for the people of where they're located at home, that they would feel the entire support and care of the healthcare system. And it would be the small packages of drugs with specific explicit instructions. And it could be simple monitoring, that we monitor you and that the entire healthcare system is holding you by your hand, although you are staying at home. We would bring you the necessary drugs, not to create the panic and not to be cross-pollinated by infections in the drugstore lines and queues. And we will be monitoring your life indicators. But the rules and regulations which are too much regulated, they do not allow us to use numerous smart devices. And the system which was recommended by the National Association to control drugs and food additives, this was brought by me in January, back in January, and it was submitted to be certified in the National Center for Expertise of Drugs. And at that time we have found no rules and regulations to cover, to make this system applicable and affordable in Kazakhstan. So I had to make specific tests that they could certify this device for dynamic supervision and monitoring as a thermometer. In other words, our system turned to be too fragile, and it was made by the conditions that we have faced. Let us look at a small example. A city outpatient polyclinic, number 10, Nur-Sultan, one of the best in Kazakhstan and one of the best in Central Asia. It has 22,000 square meters and it services 86,000 of attached population, and some 7 billion tenge were spent from the government budget. Mostly it was empty. It wasn't used while fighting with COVID. And against of this position, there was a small picture of our network. We are servicing 120,000 people in Nur-Sultan and Akmola region at 11 facilities which have 5,000 square meters. And for that we have spent 1.5 billion tenge. And each of 11 facilities were a filter which was caring for outpatient patients. And so out of 22,000 250 square meters were working, and in our facilities, out of 5,000 square meters, we had every facility being involved. So please remember, when we will be talking of creating or establishing, building large polyclinics or hospitals. And a few words about digitization. The number of medical data by 2020 has been 2.3 trillion megabytes per day, and 3.2 of that is medical data, and it's doubling every 2 months. And in coronavirus, this doubles even more often. More than 20% of them are not structured, and the level of digitization in many countries is less than in developed countries, and our country is within that approach. So the human body generates 60,000 physical indicators, so we are the largest source of data generation in nature, and this will be the biggest value in the future that we will face. The next thought, automating chaos. We are getting automated chaos. So to automate 20,000 rules and regulations and to make adequate protocols, data exchange and algorithms is impossible. We need to sort out the business processes first. We need to calculate everyone and everything. We need small data, small figures. In our country we have 1,500 acute care specialists, resuscitation specialists. And even if they work a day after day, that is 750 working positions. I have 6 years as a resuscitation doctor, and I know to work a day after day with this schedule is impossibly difficult. And the rules and regulations that were approved recently, 4.6 resuscitation beds, intensive care beds, should take 6 intensive care doctors. And that means that 550 doctors, intensive care doctors, can provide care for 1,500 beds in intensive care. And even if we buy 100,000 machines for forced ventilation, no one will service them, because the healthcare and medicine is always about people, people for people, people about people. So we think that those machines would ventilate themselves, and the beds will cure themselves, and the tomographers will do imaging themselves. No, that's done by people, and the people, they tend to be weary, to have fatigue, burdened by the ideological impediments. More than half of our people during pandemics were sent to hospitals where we needed to organize the for provider hospitals, and the patient's triage has some blind diagnostic windows even during the best time, and verification according to various sources is from 65 to 35%. And in our country we had 3 million PCR tests. That's talking about digitization. Where is all data? And if we talk about the number of people that were involved in this research, for doing this research according to protocol, that would require at least 2 years at based facilities, at available fleet of analyzers and with available personnel. So who do we want to fool? Because PCR tests became the leading in patients triage. Patients with confirmed PCR they were sent to COVID hospitals with some kind of oxygen support, that there were drugs, and all the rest with unconfirmed PCR. Even the mild, the middle, and severe patients, they were sent to pharmacist in charge hospitals. That was due to some wrong algorithms that were established. Going back to digitization, the information technologies, they support primary health care and strengthen it, especially in conditions when we, as Kazakhstan, we have very low density population. For the last year, I have traveled to 250 villages in 25 districts of 4 regions, 4 provinces. I have seen small facilities of 50 square meters, which is servicing for rural population not more than 3,000 people, and there were when at the same facilities would provide for 10,000 of population. If we go back to the rules and regulations, the legal framework, regulatory framework, those facilities have to be closed, a major proportion of them, because they cannot provide for the separation between dirty and clean areas to separate the flows. A solution could be the presence of remote diagnostic complexes and systems, but we do not want to certify them. In the huge number of rules and regulations, there were none which would help doctors to have patients at home and to become this ideology doctor at home, to make it true, to make it happen. GLOLIT Israel network, one of the most advanced in the world, reportedly takes second place in the world for the size of medical data. For 30 years they have not built no clinic, no hospital, but at the same time this is the second place for the volume of medical data. Small things create opportunities for the large things, and in the matrix we have all the structural components that are necessary, and they are available. We have government database for individuals where we're identified by our IDs. We have international classification of diseases of the 10th and 11th review. We have the rates for services. We have the register of drugs. We have expectations on facilities and buildings. And we need to sort out our digital data on personnel, because during the peak of pandemics, we did not know how many doctors are active, how many nurses. We had to count the heads of provinces, heads of facilities. We need a dashboard of people, because people are about people. So we need to sort out our regulatory framework, and we need to straighten the matrix systems and to use the protocols of best practice.
We also has to expand the database on our patients' gadgets. Very simple tool, as well as smartphones and all other carable devices which could validate our patients. And we also have to understand our financial situation, because if we would not provide proper finance to PHC, then at 10% of finance being on the 91th in the world in terms of medical spendings per capita, we wouldn't be successful. And of course, we discussed this with our superiors. We need to merge the package on obligatory medical insurance with primary health care, and then we could have a flexible form of financing. And now our practitioners have to choose between various forms of financing for every patient, and instead of expected positive impact of digitalization, our practitioners have to pick up a proper finance over a computer for every patient. There was a dark humor on American health system, which spent huge amount of cash on medical services, at the same time had very poor coverage and accessibility for population. And the whole system is under the motto, let rich people not recover and poor people not sick. And that's the only way how our medical practitioners are also thinking about so far, sadly. And now we need to rethink the way of financing, the mode of financing for our medical staff, for our medical services, validators. Validation is very important as well when we're filling up electronic passports of health status, as we call them. And I spent 2 hours with a good computer and internet access. It required 2 hours to fill up these health certificates for every individual. So you see, it would require 36 million of man hours, and of course it is quite undoable to accomplish. And here we need to establish the online ecosystem while working offline, and family practitioners under these circumstances should play an important role. We have to make our system more robust and resilient, to make our education system much more efficient, and only then we could go through such catharsis as our pandemic. Our system should not be so fragile as it used to be, but after this perjury, we need to become more resilient. And when we're talking about our heroes and our system, we also have a superhero. Kairgildi Sharmanovich is one of such a superhero. And I am at the same age as he used to be during the time of Almaty conference. And I should say that you should stay with us, because we have a lot of things to do together. Without such people like you are, we may not deliver. And I thank you for your attention.
It on such a high note. I particularly thank you for bringing issue of primary health care into the context of health systems and your focus on a very important health system lever, which is on health financing. Dr. Karibayev, any questions?
Спасибо, доктор Якаб. Спасибо.
Dr. Karibayev, your questions. Thank you, Leila, for your very interesting presentation, your statistics. Actually, you demonstrated the fact that we have more than 20,000 regulatory and normative principles in our situation, in our health system. And we have 27 so-called roadmaps and 27 orders, direct executive orders on behalf of the Ministry of Health. How all this impact on the quality of medical services? Of course, we're talking here about the fragility of our system. When we have so many systems, so many regulations, this make our system fragile. And of course, the system should be rather be focused on the KPI systems. It's just like make or learn birds to fly, how we can rely on people who deliver or drafting these regulations whilst they never seen a single hospital or polyclinic in their life. So the system is very fragile. We need to have a very simple legal framework, again based on key performance indicators. Thank you very much for your presentation.
From Kazakhstan, which of course has lots of challenges considering its size, to another country, another situation with a very, very different context, and this is Singapore. I would like to invite our next speaker, Professor Teo Yik Ying, Professor and Dean of the Sosui Hock School of Public Health. The floor is yours.
Hi there. I hope you can hear me. Great.
Hear you very well.
So,
please continue.
Thank you very much for the opportunity to speak, and it's been a real delight to be able to address this forum, specifically focusing on primary care and its role in COVID-19. In my opinion, primary care remains one of the first frontier for any situation in an outbreak, because this is where many people, members of the public, will go to primary care to seek help in the first instance before they realize that they need to go to the hospitals for greater care. So what I'm going to share over the next 30 minutes or so is really around what Singapore has done to strengthen primary care and its health system to really manage the COVID-19 crisis that is happening in our country. I would also talk a little bit about how we have increased the capacity as well as the resilience of the health system in managing the public health crisis. Now, I think it's important to highlight that in Singapore, we paid a painful lesson through SARS back in 2003. And you would see that Singapore is one of the worst affected countries with 238 cases and 33 deaths when we had SARS. It's amongst the top 5 countries affected by SARS back then. And because of that, we've learned very important lessons around how do we manage our health system, our primary care, our hospital system, and more importantly, how do we protect our healthcare workers to make sure that they are not infected in a time like crisis, in a time like COVID-19. A lot of our understanding and our health policies have changed given the evolution of the world's understanding and knowledge around COVID-19. I like to think that a responsible and a sensible government will always pay attention to the latest science and latest understanding about a pathogen such as SARS-CoV-2 in deciding what is the right policies to put in place. It wasn't too long ago in January this year that we were still thinking human-to-human transmission is unlikely, and even if it's possible, it is not highly transmissible. But right now, just 9 months later, we know very clearly that human-to-human transmission is not only possible, but is extremely likely to happen, is highly transmissible, and in fact, people can be infected and not display any symptoms at all. These are what we call asymptomatic infections. Some people will be mildly symptomatic with a sniffle, maybe a slight cold, but they are similarly affected by COVID-19. The healthcare policies, as well as the public health policies, actually have to evolve with this understanding. Because the moment we realize that asymptomatic spread can happen, this is where measures such as mask wearing, measures such as social distancing becomes absolutely important in the toolkit for any country that is trying to control COVID-19. Right now, just about 5 weeks ago, we saw from Hong Kong the first scientific evidence that someone who has been infected with COVID-19 earlier this year has been infected once again in July, August this year. So this changed our perception of what we consider as a right way to manage the COVID-19 crisis in the world. Where we know that reinfection is possible, strategies such as herd immunity is no longer relevant. Herd immunity that is obtained through natural exposure to the virus is no longer relevant, and we really need to think about herd immunity through a vaccine. So a lot of these policies constantly change based on our understanding of the situation. Let's come back to how Singapore has managed this crisis. We've gone through very difficult times because early on in the year, Singapore was deemed to have a very good handle on the situation. It was found to be the gold standard in the way that it manages COVID-19. But it wasn't too long after, just less than 2 months, in April, that Singapore became a cautionary tale to the rest of the world. Because this is how fast the situation can deteriorate and get a lot worse in any country. We have now seen, not just in Singapore, we've seen the same happen in South Korea, in New Zealand, in Australia, particularly Victoria State. Just within a matter of weeks, you can move from a situation where there are 0 cases in the community to a situation where you have hundreds of cases. And that's when you may even have to consider a further lockdown again. So some of these lessons are very important. And I think it's important to highlight now, what is the current situation in Singapore? The community cases, and these are infections that are acquired because people are moving around in the community, actually remains very positive. Because if you look in the past 2 months, on average, we have less than 5 cases in the community every single day, less than 5. For many days, actually, we have 0 cases in the community. The vast majority of our case numbers right now actually came from the migrant workers that were living in the dormitories. And because they were living in highly dense setting, this is where the coronavirus spread very quickly to people within the same room, people living on the same floor, sharing bathroom facilities, and even people within the same block of dormitory. But if we look at what is happening right now, it's really a lot to be driven by importations. That's the top panel on this particular chart, that there are 3 waves of importation that we generally think about. First happening in January, and those were mainly from people coming in from China because that was the country that was most affected back then. The second wave of importations actually arise because in March and in April, the coronavirus was spreading very quickly in parts of Europe, in parts of North America, and those were places where there were many Singaporeans either studying or working in those places. They chose to come back to Singapore. Some of them came back to the country with the infection, and that's how it started spreading amongst the community. So in fact, if you look at the plot on the top, in March, that's where there is a peak for importations. 2 weeks later, there is a peak for community cases. And around 2 weeks later, it entered the migrant worker dormitories. And that was a major peak, affecting thousands of migrant workers. In fact, at the peak, we had about slightly less than 1,500 migrant workers being infected every day. And so that's the main risk right now for a country like Singapore. How do we manage our importation risk? And you could see we are facing the third wave of importation right now. And these are people that are returning to Singapore because they work here with a long-term work pass, but because they've been quarantined the moment they arrive in the country. So even though some of them turn out to be positively infected, we are not too worried because they will no longer spill over to the rest of the community. And that is why one of the key messages that we have right now is that the way we manage our borders for any country, it's still the most important aspect to manage the risk of COVID-19 transmission in the country. Now, I talk about the spread within Singapore amongst the migrant workers, and you could see how quickly it spread to different dormitories because of the way that they were working, because of the way they were living. Some of these migrant worker dormitories house thousands of migrant workers. And that is when it enters a migrant worker dormitory, it spreads very quickly, and it gets worse if it enters multiple dormitories. And in Singapore, we have many different dormitories housing the migrant workers. And unfortunately, it entered quite a number of them. So how did the country respond? And I think when I talk about primary care strengthening and increasing surge capacity in the healthcare system to look after COVID-19, this is really where the reliance and the reference to science, to the latest evidence, makes a big difference. Because from the very beginning, we were relying on information. Our policymakers were receiving weekly updates on the latest science, including the characteristics of infections, where we know actually many people who are infected will either remain asymptomatic or mildly symptomatic. It's only people who are older, who suffer from comorbidities such as obesity, diabetes, hypertension. Some of these conditions will put them at higher risk of complications. By making use of this knowledge, this is how Singapore was able to manage the demand for our healthcare resources. I will talk a little bit about that, but you could see from the very beginning, back in January, our policymakers were receiving guidance from the scientists, from epidemiologists, from infectious disease modelers that were producing models like this to inform the Ministry of Health what is the likely degree of spread in the country over the next few months. Linked to that, what is the strain on your intensive care units, on your hospital beds, on your mask, on your ventilators. By being able to manage your resource allocations, that is a very important way to keep the situation, the clinical situation in check. And it's not just the clinical situation, because the same approach, the reliance on science and models, continued to look at what are the measures that should be adopted in the community. Should we close schools? Should we have a lockdown? Should we shut down workplaces, public transportation? All of this were modeled, and the information were used by our ministers, our policymakers, in deciding what were the stance that Singapore should adopt. So when I talk about the clinical response and the strengthening of primary care, bear in mind that a lot of this were guided by scientists, clinicians, epidemiologists, public health practitioners. Now let's talk a little bit about Singapore's healthcare system, and specifically, I will ask you to focus on the second column, which is on primary care. You would notice that Singapore's healthcare system on primary care, predominantly it's private practice. And that is a very important element that every country has to understand. How is the healthcare system in my own country operated? Is it primarily public funded hospital, public funded primary care, or is there a mix of private and public? Because during a crisis like COVID-19, your ability to galvanize and your ability to command even the private care settings, especially primary care, becomes absolutely important. So Singapore's primary care was 80% privately operated by GPs, 20% public, and these are government-funded polyclinics. And based on that, this is where we realize that during a crisis such as SARS, such as H1N1, and such as COVID-19, we must be able to work with the private primary care operators in a manner that is nationalized, such that there is no confusion, there is no mixed messages to the patient or even to the doctors themselves in terms of how should we care for affected and infected people. This is very similar to some of the settings in the United Kingdom where there were fever clinics that were set up. And by the ability to command private hospital and private primary care during COVID-19 has turned out to be absolutely important. And this is where I will now talk a little bit about what we did as a country to prepare our healthcare workforce, not just in the hospital, but also in primary care for a respiratory pathogen, such as H1N1, such as SARS-CoV-2. After SARS, we realized that everyone in a polyclinic, in a primary care GP, in a hospital, must have that level of vigilance and awareness that there could be an infectious agent that is spreading within the community until much later when we realize there is an infection spreading. So hospitals, receptionists, nurses, doctors, they are all trained to look out for signals or symptoms where someone may have reported coming back from travel, reporting high fever, coughs, and that simply doesn't go away. And these patterns are observed recurrently. And once you see that there are a few recurrent patterns coming in, the hospital very quickly actually will operate in a crisis manner. And they actually undergo annual preparation drills, very much like military drills, military exercise, where someone will pretend to come into a hospital with certain symptoms and with a travel history. And the hospitals are given a measure of how fast they respond to protect the healthcare workers, the nurses, the receptionists from any respiratory agent. How quickly are they to realize that we need to activate a respiratory infection protocol? And this has made a massive difference. Singapore right now, we have around 58,000 people confirmed with a COVID-19 infection. Our death rate, it's 28. Regrettably, 28 people have died, but out of 58,000, 28 is a very low number. We have been very fortunate to be able to keep to that low number. More impressively, less than 10 healthcare workers in Singapore has been infected with COVID-19 because they were performing their duties looking after other patients. Less than 10. And I see this really to be a measure of how well primary care, hospital care, the health system in general has been able to prepare for a crisis like COVID-19. I talk about increasing the surge capacity. And this is where, again, the reference to science, to the understanding of infection, to the clinical characteristics becomes very crucial because we realize that the majority of people are actually going to recover by themselves with very mild symptoms. Some of them will go through painful symptoms, complications, which right now we call it long COVID, but more than 80% of them will have very mild symptoms. And is there a need to take care of this 80% in a hospital where you're using up precious tertiary hospital resources? In Singapore, we set up few hospital facilities in exhibition halls. We convert these exhibition halls into temporary hospitals, such that people with mild or no symptoms are all housed in these facilities. They are not sent back home to recover at home, but they are all housed within this facility such that they can recover. And I think this is a very important way to increase your capacity to look after patients. And of course, when you have few hospitals, you need to have people who are able to cope with additional demand, which is very much like a primary care setting, looking after patients, providing minimal care, basic care for this. This is where deployments, volunteers, even people who are previous healthcare workers coming out of retirement to work in some of this community isolation, few hospitals, have been helpful to increase the capacity in the health system. I talk about the migrant workers being representative of the majority of the spread. And this has been a painful lesson for Singapore, because we realize that our ability to cope in a crisis really depends on how well the country is looking after its most vulnerable sector. Because Singapore, prior to April, we had a situation that is very well under control. But perhaps we could have done better in looking after the migrant workers such that we avoid infection happening within the dormitories. But the moment it entered the dormitories, you could see very rapidly from a situation where we had less than 10 cases in the community per day, we went to a situation where we have almost 1,500 cases in a single day. More than 98% of them were migrant workers. So that's why we put in place the necessary precaution to look after the migrant workers. All dormitories had health posts, had medical posts that were established. These are your field primary care clinics that were used as the first line of triage to make sure that any migrant workers with possible symptoms are immediately identified, evaluated, swabbed, tested, and then subsequently quarantined. And even while during this period of lockdown and quarantine, migrant workers, in order to make sure that they are well looked after, Singapore government actually continued to pay their salary, confirm there's an assurance of salary during this period of quarantine. And that actually helped to manage quite a lot of the mental stress and the fatigue for these migrant workers. But unfortunately, over an extended period of lockdown, we are starting to see there was strains happening and there's increasing signs of mental distress. So right now, we have a way of understanding the problem. And I think it's in the Singapore's approach that we don't run away from the problem, we identify, we own up to the problem, and then we try to find our way to address some of these problems. So I talk about importation risk as one of the biggest hurdles. In Singapore right now, our borders remain completely shut to the majority of the countries around the world. We have several green lane, essential business travel arrangements with several countries in the region. We actually will have a travel bubble arrangement with Hong Kong, where there is no quarantine that is necessary because the community situation in Hong Kong and in Singapore are very similar. We have very low community transmission. But for the rest of the countries, if you are a Singapore citizen, you're allowed to come back in, but you have to be quarantined for 14 days, not at home, in a government facility. And Singapore, we were able to manage the situation within the community back then in January and February, as well as right now, because we put in place quite a lot of measures to perform contact tracing, very rapid contact tracing, such that we are able to quickly identify who are the people that have been exposed and isolate these people quickly. So I think it's very clear that the value of contact tracing has been reiterated repeatedly by the World Health Organization by identifying your potential carriers, especially right now when some of these carriers could be asymptomatic in nature. You're able to quarantine and isolate them such that you cut off any further interactions with the community, thereby driving further spread. And we know for many conditions that the earlier you intervene and identify someone who's infected, the earlier, the better the clinical outcomes. And I think this is another reason why our death rates remain very low. Contact tracing also provides a very important source of systems level understanding of two scenarios. The first is to find out how bad is the situation in the community. Because if you are starting to see a lot of clusters emerging where they are all unlinked, it actually means that the situation in the community is much worse than you think. And secondly, by performing very thorough contact tracing, we actually get an understanding of what are the measures, what are the activities and the settings that are very high risk. And in Singapore, we realized very early on through contact tracing that karaoke singing is one of the highest risk activity that people can indulge in, because that's where they talk by singing, they project a lot of droplets and aerosolized risk, and that's where the risk is very high. Contact tracing clearly is manually intensive. Singapore tried to rely on technology and is still trying to adopt technology to facilitate this process of contact tracing. But we realize that there are realities towards digital contact tracing as well. The theory sounds very useful because digital contact tracing means I can just download information of who I have been in contact with prior to me turning positively infected. So I can perform this contact tracing quickly, comprehensively, with very little recall bias. You don't need to rely on a person's memory to decide who he or she has been in contact with. Very much lesser reliance on manpower. That's the theory. But actually the reality is that who adopts the technology matters. And when it comes to technology, often the elderly, the very young children are the ones that will not adopt this technology well. And also, it depends on whether you're able to triangulate the signal well. What do I mean by triangulating the signal? Remember, when I'm in a room that is separated by a wall, this digital contact tracing relies on Bluetooth signals to link up to identify who is in my vicinity. Some people I may have zero physical contact with, but they were separated by walls. So in my mobile phone, I could have thousands of contacts in my phone, many of which actually will not have a genuine or meaningful physical interaction with me. There were technological barriers as well as privacy, confidentiality concerns as well in the adoption of digital tools. And at the end of the day, it was very clear that there is still a need for well-trained contact tracers. And that's why in Singapore, we've been thinking of moving beyond a mobile technology approach to relying on distributing some of these tokens that you see these two elderly gentlemen carrying with them. It performs the same approach to trace the interactions of people that we come into contact with. Finally, I will just highlight the bit about the monitoring and enforcement of the rules. You can put in place all the primary care, hospital care, resilience or plans. But if you don't have a way to properly manage your community transmission and you allow the virus to spread indiscriminately in the community, no amount of primary care and hospital resource will be sufficient to look after the population. So whenever a country puts in place public health measures, such as mask wearing, such as social distancing, specific rules on limiting the interactions between people, the question is, are any of these rules enforced? By enforcing this, you send a very clear signal. Those rules matter. If you break the rules, I will punish you. And in Singapore, we have never been very shy to punish people who break the rules. We will be fined. We will fine people if they go out in public without a mask or if they're socializing in large groups. So in conclusion, When we think about managing a health crisis like COVID-19, primary care remains the first line of defense. And we have to always think about how do we manage primary care in a local context setting. In the United Kingdom, primary care is primarily publicly owned. And that means you have an easier way of commandeering your resource. In some countries, including the United States, primary care could be entirely privately owned. And how do you nationalize this during a time of crisis? In Singapore, when we think about strengthening the health system, this is where we actually do not rely solely on the tertiary care sector, the hospital sector, but we also look at how do we increase the capacity in our primary care sector, as well as setting up primary care fever clinics in different segments that are most liable to see more infection, such as in the migrant worker dormitories. In terms of our control mechanism, we still rely very much on contact tracing, on testing, and more importantly, on the rapid quarantining of exposed individuals to cut off transmission chain. Singapore is one of the countries that remain to be tightly controlled in terms of social measures, in terms of measures that individuals have to take. And more importantly, we make sure that people keep to those measures by continuing to monitor, to enforce the measures, and crucially, to punish people if necessary when they flout the measures repeatedly. With that, I will stop here, but I'm very happy to take questions both around the health system in Singapore and broadly around some of the measures that were put in place. Thank you very much, and over back to you, Chair.
Thank you very much, Professor Ying, for this very rich presentation. I very much enjoyed how Singapore's response was tailored to its very specific problems, and I very much enjoyed listening to your thoughts around creating surge capacity involving primary healthcare and the role of contact tracing. It's indeed areas that most European health systems are really seeking to strengthen and improve. The first question is related to the health workforce. We are seeing in a number of countries that the increasing burden on the health workforce can lead to burnout. Has Singapore provided psychosocial support to health workers beyond let's say, the average state of policies?
I'm afraid I can't hear any of the questions that have been asked.
Oh, okay. Just give us a second.
Is it possible for the question to be repeated again?
Do you hear me now, Professor Ying?
Вы повторите
Do you hear me
вопрос.
now?
Professor, I could relate to you the question. Can you hear me?
Yes, I can. Thank you very much.
Okay, very good. So let me just repeat my thanks to begin with for your very rich presentation. It really was very interesting to hear how Singapore's response was very specifically tailored.
Your response was specifically tailored to problems and issues that you have encountered. And the question which we would like to raise with you is whether Singapore is providing any special, extraordinary psychosocial support to health workers. Because in a number of countries where health workers had to mobilize for surge capacity as well, that the past 9 months have left an enormous burden on them, and they were burnout in many instances, and they're seeking good ways to provide psychosocial support. So what is your experience on that?
Thank you very much for the question. So in Singapore, indeed, some of our health workers, we have reported that they are under some degree of strain and mental stress, especially because they were worried that they will be infected and they will go back home and spread the infection to their children, to their parents. And that has been one example of the kind of mental stress and fatigue that our health workers have been undergoing. In Singapore, we address this in 3 aspects, and I will highlight what the 3 aspects are. So the first is actually to make sure that the health workers are properly trained. And there is no greater assurance to the health workers when they know that they have the knowledge in terms of the use of PPE, in terms of the procedures that they take to intubate some of these patients, that they themselves will be protected because they are well trained. So by ensuring that the healthcare workforce is well trained, actually it turns out that that has addressed a significant part of their own stress and pressure, because they know I have a much lower chance of being infected because I know the right thing to do in this setting. So that's the first. The second was, from the very beginning, all of our personal protective equipment were prioritized for the healthcare workforce. So in January to March, worldwide, there was a shortage of masks, surgical masks, surgical gowns. And in Singapore, because of SARS again, there was actually a national stockpile of all this essential personal protective equipment. And this were made available to the healthcare workforce from the very beginning up until now. So in Singapore, no healthcare worker ever had to run the risk that I will have to enter a situation in a clinic, in a GP, in a hospital, where I do not have the necessary equipment to protect myself. And then the third is to constantly communicate to the healthcare workforce in terms of what is the latest situation in the country, what is the latest situation in the hospital or in the clinic, such that the healthcare workers themselves, they know precisely who are the people that are infected, the patients, who are the patients within this hospital that are COVID-19 patients, where are they housed, how are they looked after, are they in isolation wards, are they in intensive care units, such that the healthcare workers themselves had a very clear understanding that if I'm working in this particular part of the building, in this ward, actually I have almost zero risk of being exposed to someone with COVID-19. This kind of communication and interactions between the hospital management back down to the hospital staff, whether it is receptionists, whether it is the cleaners, whether these are your nurses and doctors, that has made a big difference in ensuring that the healthcare workers themselves are kept informed of the latest development. One of the biggest difference that I see between Singapore and other countries is that for any of our healthcare workers who were uncomfortable to go home because they were working in a hospital where there were COVID-19 patients, they were actually given a chance to stay in one of the hotels near the hospital, all paid for by the government. So they will never have to worry about the risk that I'm bring the coronavirus back home to my family. Anyone that were worried during the peak months of February, March, April, May, they were given the option, if you're worried, we will put you up in a hotel setting. You don't have to pay for it. We will take care of the bills. And that sends a reassurance. And I think for many of these healthcare workers, the allied health workers, the pharmacists, the nurses, the doctors, there is nothing more reassuring to know that actually the government, the management of the hospitals, put in place protocols to look after their health and also to think about their family. That actually has helped to address a lot of the mental health fatigue as well as mental fragility in amongst the healthcare workers. So I will stop there, and again, I'm happy to take further questions. Over back to you, Chair.
Thank you very much.
Thank you very much
Your
indeed.
response is an
Your
example
response
of how
demonstrates
compassion and empathy.
an example of passion and empathy. I want to thank you again for your presentation.
This morning's session, we will move to Lithuania, and I'd like to invite Professor Ramūna Kaledienė, Dean of Public Health Faculty, Lithuanian University of Health Sciences. The floor is yours.
Dear colleagues, I just try to share my okay. Can you see my screen?
Not yet. Now. Yes, excellent. We do. Go ahead, please.
Okay. So, dear colleagues, dear participants of the conference, it's a great pleasure for me to share Lithuanian experience with you. And Lithuania was among the countries which was managing first wave very well, I would say, relatively. And the first case of COVID-19 was diagnosed in February 28th. And after 2 weeks, we immediately implemented lockdown measures. So in fact, as you can see from this slide, the first wave was rather small, and our healthcare system didn't have any burden. It was not overloaded. But what happened that society was really suffering from the lockdown measures because it took quite long, and the economy was stopped, and psychological problems started to appear. So I would say that people got tired from the warning signs and from bad messages. And when summer came, everyone was relaxed, released, and started to forget this disease. And that was, I think, really very worrying sign for us. So what is happening now? Now we see very rapidly increasing cases of COVID. And in fact, it is really scary what's happening now. With our mathematicians, we developed some prognostic models, which you can see here, what can be expected in the country. So this case A is what happens if we have social distancing and all measures which are taken in the society as if it was in September. So you can see that it's really a rapid increase of cases. And if we don't enter any more strict measures and the local or total quarantine measures, we would have case C. So it's exponential growth of the cases. And of course, there is case B, the red line, when social distancing is as if in October now, because now we are starting more and more strict measures to be implemented. So if we continue in such case, we would have case B, which is, I hope it's realistic. But just at the moment we have elections, and it very much depends on the party which wins, because now there are very, very contradicting messages appearing out of the different political parties, how they will manage pandemics. Because there are a lot of discussions on the Great Barrington Declaration with very, very free and not restrictive measures applied to these pandemics, and there are opposite ideas like for implementation of quarantine. So in fact, we are, I would say, in our country, we are at the crossroads, and we don't know what political party will win and who will take which decision. So here we can only show to our politicians and to our society the prognosis what might happen. So we are analyzing population mobility data from Google, and we see that we can have some data on how many people are going at work, how many they stay home, and our mathematicians, they calculated a combined mobility risk indicator. So I want to share with you now a comparison of Kazakhstan case and Lithuanian case. So these red columns, red parts, they are showing increased mobility and, of course, increased risk of spreading COVID. So as you can see from this slide, in Lithuania, we are in much greater risk if compared to Kazakhstan, because in Kazakhstan, you still have much more green area, green columns, while in Lithuania, it was really very bad some months ago. Now it's improving a bit, but still we have much higher risk of spreading COVID if compared to Kazakhstan. And here I wanted also to share with you combined mobility risk indicator, where we looked at Kazakhstan, some Eastern European countries, and some other countries. So again, if you look at the bottom, so you would see that this is blue line Lithuania. So we have very, very varying, very big waves of combined mobility risk indicator, which mobility increases significantly during weekends. People are traveling, people are moving, people are gathering, while for example, in Kazakhstan, it's completely different picture, in fact. So what we can conclude from this mobility data, that it's mobility levels are, of course, about 30% below that of the beginning of 2020. So it tells us that population is still working remotely, many of people, but generally Kazakhstan and Kyrgyzstan have overall higher decline and following the lower risk of mobility than, for example, Russia, Turkey, or Lithuania. So in summer, we started to think about one important question for Lithuania. What is the situation about immunity against COVID-19? And how many people in Lithuania had so-called silent version of the disease without symptoms? So we decided to make a survey, a representative survey of Lithuania, and it was calculated that we need about 21,000, nearly 22,000 of people, adult population we decided to select them from 6 different regions with the highest, medium, and lowest prevalence of COVID-19. And people were invited for testing, immunoglobulins M and immunoglobulin G, using rapid tests made in Austria. So what we didn't expect, that response rate was extremely low, only 14%. And it shows us that, in fact, our population lost awareness because it was summertime, cases were very small, just few per day. And people, they simply didn't want to come and give a drop of blood for the test. So, but anyway, seropositivity was also very low. It varied from 1.3% in capital city Vilnius to 2.8% in Kaunas, in the city where we are, where we live. And what was very interesting, that 2/3 of seropositive persons were asymptomatic. They didn't get any symptoms. They didn't know that they got the disease and immunity. And seropositivity was high in the age group from 18 to 59 in comparison to older population. So what from this? So what we see that, in fact, our population is not immune against this disease. So generally, you know, everything is in front of us. And our population is not really worried up to now. It wasn't really worried what's happening. So what we think now and what we do now, we are sure that effective and continuous monitoring of situation is essential. And contact tracing is very important. What's happening now with contact tracing? We have really very many cases every day. It's about 250, 200 cases every day, which is very high for Lithuania, being really a very small country. In comparison to summer, we had 2-3 cases per day. In spring, when quarantine was implemented, the biggest number was 55% per day, 55 cases per day. So you can imagine that this is 5-6 times higher at the moment. And in fact, delivering relevant information on this is very important. And as I already mentioned, in spring, our society, our population was really scared. There were very bad, very nasty news every day on TV, on mass media, while now, having in mind psychological well-being of the society, economic well-being of society, somehow it changed, and we don't have this bad news. We are just having very objective situation. Every day, of course, everyone is informed about numbers of cases growing and spreading. And what is very worrying, that we have more and more cases which are not traced with the contact. So contacts are unknown, and the way of spreading virus is not detected very clearly where a person got it from. So we have, of course, continuing information for society that physical distancing, social distancing is very important. But when we look at real life, we see pubs full of people, we see shopping centers full of people, and I think it will gradually came this understanding that this is really not a game, this is very serious. So testing is very important, and what we observe now, that people started to avoid testing, and we observe some cases where people with symptoms of disease, they don't go for testing. So this is very big challenge for the society, which is really very democratic, very mobile. So it's quite a challenge for us to control it and to manage and to trace all contacts. There are a lot of discussions for allowing people to get the disease, to take Swedish example, to take other very voluntaristic examples of countries for just focused prevention, just for tracing the most intensive places of the disease, not going to national restrictive measures. But of course, here I hope that researchers and scientists, they would say the final word, and it will not be left like this, especially having in mind very low seropositivity of the disease in Lithuania. Imagine only 2% in somewhere were immunopositive. Very important is ensuring sufficient physical infrastructure and workforce capacity. So, in September the 1st, our schools were opened, our kindergartens were opened, universities are opened, and what we see now that there are more and more spots of the disease occurring in educational institutions. Also at our university, let's say yesterday we got message that one of our students got COVID-19. So from today we stopped all second year students course, but other students, they are still on face-to-face training. Of course, we are asked to have as less contacts as we can, but anyway, for medical training, as you can imagine, it's inevitable. So what about our healthcare services? As I mentioned, in spring, we had just few cases and it was not overloaded at all, so we managed very well. And of course, we have discussions like I liked very much previous speaker and example from Singapore about separate hospitals for these patients. So we discussed this about so-called mobile hospitals, but it didn't come into reality at the moment. And what we see now, that gradually our hospitals become fully, burdened by these COVID patients, because we don't have separate place for them to be treated. Another very worrying thing in the country is that now hospitals, general hospitals, also having more and more cases diagnosed, and it disturbs work of our plant services, of our other disease treatment. So we have to act very quickly. And now, of course, there are new methods developed from the spring experience. So I think this is very good, that when only COVID is diagnosed in some healthcare facilities, immediately they not completely close it, but they move it to another environment and they continue services. Like, for example, a few days ago, there was a break of COVID-19 in our university hospital surgery department. So starting from today, they are working in another infrastructure, providing plant services for ordinary patients. So I think that generally our hospitals are quite well ready. Just the problem is that we don't have separate infrastructure for these patients. What we are observing, I think it's universal, it's worldwide, that the cases become less and less serious. So there are a lot of people with very mild symptoms, and lethality is declining. Now, generally, we have about 113, I guess, cases of diseases related to COVID-19, so it's not much. And I think this is because we have much younger population affected by COVID. And of course, treatment algorithms are better developed. But here, I think the same issue like in Singapore, that we have somehow to switch it more to primary healthcare facilities, not to hospitalize all those patients with mild symptoms. For that, it's really very intensive planning and reorganization of health services is now in the process. The same is true about preparation for vaccination when vaccine arrives, and preparation for more flexible diagnosing and testing of COVID-19, because at the moment testing is only done in special points, special blocks. So what we talk that it has to be more flexible, more accessible for people, not to wait, let's say 24 hours until my term comes to be invited to be tested. Of course, sufficient financial support for services and for doctors is essential. Of course, our government gives huge efforts and huge flow of financial support. So at the moment, we don't feel it, but we don't feel a scarcity of resources at all. But having in mind that this is not a short problem, it's a long-lasting epidemic. Now we see that we have second wave, which is much higher. Later we might have the third wave, and so on and so far. So this financial support has to be sustainable, so very well planned. And what is very important is active community involvement and support. This is, in my opinion, essential thing. And we have to be very clever in spreading the knowledge, spreading the evidence, and stopping, some ideas of some groups which are completely against everything, against vaccination, against isolation, against face masks, and so on and so far. I think they are active everywhere, but in Lithuania they are particularly active, proposing different strategies, and of course having some evidence that this is not working, or this is against human rights, or this is damaging our economy. Yes, we understand that we all have to sacrifice something, and we have all to be supportive. So luckily our mass media already changed a bit the focus, and more and more we have our mass media as supporters of evidence-based information. And what we noticed during those months of pandemics, that chronic diseases, management of chronic diseases became very huge issue in Lithuania. So especially cardiovascular diseases, especially cancer treatment, because access to healthcare of those patients was reduced, and planned services were postponed. What else? Just recently, we had national public health conferences and listened for people coming from public health area, from the field, from the regions. And what they noticed, that lifestyle risk factors started to grow again. Generally, Lithuania was in a very positive trend recently, and worldwide, we were, in comparison to other countries, we were doing very well with managing lifestyle risk factors, like obesity, like blood pressure, like nutrition, like physical activity. So what is very serious worry, that during the times of pandemic, we cannot stop working on lifestyle improvement. We cannot forget it, and we cannot allow people to go back to this pattern of developing lifestyle related diseases, chronic diseases. So generally, I would say that we managed first wave very successfully. But now we are facing second wave, which is of different character. And my question, which I raise for myself continuously, is it good that we had, in summer, when we did this seroepidemiological survey and we got very low seropositivity, is it good or bad sign? From one point of view, it's good because, okay, we managed the disease in spring and therefore people didn't get it. But now when we look at the future and we have so small percentage of people with immunoglobulins against COVID-19, of course we understand that it increases the spread of disease. But my opinion is that achieving herd immunity through natural infection is unethical and, of course, unachievable at all at the moment. Not at the moment, but in the coming year, I would say. However, this so-called focused prevention is under very, very important discussion. And now when we have so rapidly increasing cases of COVID in Lithuania, we started implementing so-called local quarantines when one city or region with highest incidences of diseases is under so-called local lockdown. Of course, it's not very strict, but anyway, some institutions have limited time for work. Some social gatherings are closed or banned for a while. So this is coming, but we're not sure how long it will work. So contact tracing is a problem, and I didn't mention, I want to mention it now, that what we're facing now, it's lack of public health workers in the field. And being Dean of the School of Public Health in Lithuania, from one point of view, I'm happy that public health profession became very needed, very notable, and very important. And now everyone openly started to discuss that, okay, we underestimated the importance of public health profession in Lithuania, and now we see that they are badly needed. Their salaries have to be increased because it was really underpaid, under-evaluated profession up to now. Of course, reaching this right balance between epidemiological and economic approach is very challenging, especially now when our government, as I mentioned, is changing in those weeks, and we had, government which took very strict lockdown measures. They managed first wave, but they are not very loved by our businessmen, by our young population, because they got tired of those restrictive measures, and this is now a problem. And provision of routine healthcare services, I think it's one of very, very important challenges which we are facing now, and we will face it for the future for sure. And I'm very happy that such conferences like this are organized and we can share experience, because I'm sure that in this pandemic, worldwide problem, it's essential to share countries' experience. And I was really happy to listen to the previous presentation, and I think I learned a lot, and I hope that you also can learn from Lithuanian achievements, challenges, failures, and successes. Thank you very much.
Krista,
Candid and honest reflection on some of
I
the
liked
facts and
your
on some of the
honest
science
reflection
and the policies.
on the facts and policies.
One question back to you is you seem to have very refined and very interesting data and information about population attitudes, population mobility patterns. Do these influence decision making for the next phase? And are there discussions of more refined public policies? What we saw in the spring is very generalized lockdown measures, very bulky, affecting the whole population. Whereas what we're seeing in many countries now is taking advantage of information as such and focusing on specific populations, specific mobility areas, specific locations, even in urban areas where we see a lot of interaction among people. Is this data influencing the policy making for the next phase?
You know, I'm optimistic about the
And our morning session on an optimistic note, we have reviewed experiences this morning from New Zealand, Japan, Kazakhstan, Singapore and Lithuania, and we have learned a lot of lessons. Reflecting on these presentations, for me in particular, there are three important lessons that come together.
The first one is that there is really no magic bullet. There is no one single intervention that will reduce transmission or will cure people, but there has to be a whole of health system and a whole of society response that starts with leadership, and not any kind of leadership, but compassionate and empathic leadership that understands the plight of the disadvantaged, of the poor, of the health workers, and a whole range of groups in societies that are carrying and shouldering a big burden. So leadership is absolutely critical, both in terms of political leadership, but leadership for formulating the right policies. And I think in almost all the presentations, there was a focus on evidence-informed public health strategies and clinical strategies. And being able to generate this evidence and bring it to political decision-making and use it for the benefit of the population has been a very important success factor in all the 5 countries we were talking about. It's not just about the public health strategies, however. We also had powerful examples how evidence and clinical evidence was very rapidly transformed into treatment guidelines and transmitted to the front line, so to say, for the benefit of the patients. For me, the second learning point is really around this idea that we are going through phases of unprecedented learning at an unprecedented speed. When we talk about evidence-informed policies, one of the factors that impedes that relationship, very often the very long lag time between evidence is generated and then there is uptake either by policymakers or clinicians at the front line. What we're seeing in the current pandemic is very rapid generation of evidence, very rapid translation into knowledge and policy recommendations, very rapid uptake into policy formulation and formulation into improving clinical practice on the ground. I believe that countries that are able to do this and take advantage of science, they're making much more robust public health policies and clinical policies as well. The third area is that's a big lesson, is that countries that were well prepared for such an emergency, they were better able to respond with less haste in a more organized way and putting less burden on the health workforce and the population as well. And in that, the Singapore response really stands out as a very well prepared response. And we heard the contrary as well, that the pandemic revealed underlying foundational problems in health systems that were not necessarily generated by the pandemic, that were not related to the fact that we don't know enough about this current virus and its modalities, but it revealed underlying weaknesses in our public health system, in our primary healthcare system, in our way of absorbing new evidence, in the way we fund healthcare providers, and in the way our health policies protect and support the backbone of our health system, the health workforce. And that suggests to me that going forward, there's a lot to learn from this pandemic. Not only about this virus, not only about how we can best respond to it, but also to take stock of our weaknesses in our health system and how we can strengthen them for future such situations. It's not just the specific of the COVID-19 pandemic, but important lessons are to be learned about the overall strength and weaknesses of our public health systems, primary healthcare system, overall service delivery and financing, so that we can build them back better for the future, make them more robust, not only to handle essential health services, but future emergencies as well. I thank all our speakers today who brought their knowledge, experience, and passion to the discussion. I thank all of you who contributed with very good questions. And we close our morning session, and I invite you to join us again at 5 o'clock this afternoon by Almaty time, where we will continue with our program. Thank you very much.
colleagues, welcome to the afternoon session of our conference on International Scientific and Practical Conference on Primary Healthcare and COVID-19 Pandemic. And this morning we have really brilliant presentations from several countries, starting from New Zealand, Japan, Lithuania, Kazakhstan as well, and I really think that we had a beautiful possibility just to learn about the situation on COVID-19 today and the role of primary health care in the fight of COVID-19 pandemic. So this afternoon we will have four speakers. Maybe geography will not be so broad, but anyway we will have the real professionals from Kazakhstan, and some of the presentations will be from United States of America. So I will start with first our speaker in our afternoon session. I would like to present Dr. Mahabat Bekbosinovu, who is acting chairman of the Board of National Scientific Center of Cardiosurgery. Dear speaker, the floor is yours. We can start.
Thank you, dear colleagues. First of all, I want to thank the organizers of this conference for the opportunity today to listen to interesting reports and share my observations. First of all, I want to congratulate Toragili Sharmanovich on your birthday. I want to wish you good health. I want to wish you great creative plans, and I want to say that you are a colossal example for us as a professional and a citizen of our country. Thank you very much for being you are. Dear colleagues, let me continue my presentation. In June, August this year, when there was a large of COVID-19 infection, our cardiac surgery center was transformed into a COVID center. We admitted 241 patients, among whom 58% were men. The average age of patients was 57 years old, and about 1/5 of the patients had severe forms of the disease. The average duration of patients, excluding the intensive care unit, was 11 days. More than 1/3 of those admitted with respiratory failure has oxygen saturation below 90%. Out of 241 patients, 16% required more support, 40% of artificial lung ventilation, and unfortunately 39 patients died. Later, these patients began to return to us with various complaints, which stimulated us to search for data, what happens to the patient after COVID-19 viral infection. In June 2020, Journal of Medical Hypothesis published letter called Into the Looking Glass, Viral Syndrome Post-COVID-19. The authors talk about what post-COVID syndrome is, why it is characterized by very severe fatigue, and most likely it is associated with neuroimmune disorders. The article describes that after an acute attack of SARS, some patients, including medical workers, develop chronic fatigue syndrome or mild encephalomyelitis, which for almost 20 months prevented them from returning to work. But in addition, the patients develop depression and have impaired sleep. Another study, which was published in the Journal of Medical Virology, also highlighted the patients with very severe pneumonia COVID-19 infection developed post-COVID fibrosis, which caused severe shortness of breath, coughing, but such patients required mandatory lung rehabilitation, which included support of the immune system and breathing exercises. In addition, most patients experience fatigue. I like how it says here that information on the treatment offered at the post-COVID clinics and the subsequent response would be invaluable to healthcare workers worldwide who, after facing the first wave of COVID, are now suddenly battling this new post-COVID syndrome. Because if you notice that there are a lot of patients of working age, the average age of our patient was 57 years old. So today cannot return to their normal work activities, and this is also one of the significant factors that can put a burden on the economy of the state. If you go back to the pathogenesis of COVID-19 infection, one of the important points is the injury of the vascular endothelium. ACE2 is expressed in the intestinal epithelium, vascular endothelium, and kidneys, providing a mechanism for the multi-organ dysfunction that can be seen with SARS-CoV-2 infection. A non-invasive method for assessing post-occlusive changes in the diameter of the brachial arteries uses ultrasound. In this case, temporary occlusion is achieved by imposing a cuff on the shoulder, the pressure in which exceeds the systolic pressure. Using a high-resolution ultrasound probe, the change in the diameter of the brachial or femoral artery in response to increased blood flow was determined. We performed a test to examine endothelial dysfunction in these patients. The picture shows a normal state. Before the test, the diameter of the vessel is 0.4 and the speech is 141. After the test, we observed dilatation of the vessel. The diameter of the vessel increased and accordingly the flow rate decreased. Another case, a patient with concomitant hypertension and diabetes after undergoing COVID and recovering from it. Endothelial dysfunction persists and the diameter of the artery after the occlusion test does not show signs of dilatation even after 4 minutes, and the pulse wave decreases. On this slide, we give an example of a patient who did not have arterial hypertension and diabetes mellitus before COVID infection. After the previous infection, the patient developed the same severe endothelial dysfunction as the previous patient. Endothelial dysfunction is manifested in the fact that the diameter before the test and after the test remains the same, even becomes slightly lower. Team of School of Medicine, Vita Salute Run Raffaele University, Milano, Italy, set up a multidisciplinary COVID-19 follow-up outpatient clinic to identify and address the clinical needs of COVID-19 survivors. The multidisciplinary assessment comprises a complex physical examination, respiratory evaluation, nutritional assessment, neurological examination, including cognitive tests, and mental health assessment. All data are prospectively collected and blood is sampled for biobanking. Continuous patient monitoring might give an answer to the numerous unsolved questions about what comes next in this pandemic and beyond. This will help physicians and researchers establish strategies to face future pandemics and develop preventative and therapeutic strategies for similar deeper inflammatory conditions. Such post-COVID centers are now established in all countries in clinics that treat patients with COVID-19 infection. During the acute phase of COVID infection, we observed in patients with development of acute coronary syndrome, myocarditis or arrhythmias, which could lead to sudden cardiac death. But what happens then when the patient has this infection and when he comes to us with arterial hypertension, atherosclerosis of the coronary vessels, diabetes mellitus? We observed 3 cases of patients with post-COVID syndrome who returned with problems in coronary artery. In September, 3 patients required revascularization, coronary bypass grafting. Post-COVID period, this patient presented with cardiac arrhythmias in the form of ventricular extrasystoles, which disturbed him against the background of severe fatigue. These are the findings that we see today in patients with post-COVID syndrome, where patients who had some problems with the cardiovascular system of pre-COVID infection. But those patients who did not have problems, they now come to us with newly appeared arterial hypertension or with dilatation syndrome or heart rhythm disturbances that have risen already in the post-COVID period after acute phase. A lot of research is now being carried out in connection with neurological disorders in the post-COVID period. Patients who either had any pre-COVID infection, problems in the form of encephalopathy due to arterial hypertension or atherosclerosis, diabetes mellitus, or they appeared for the first time after COVID. These patients must be examined by a neurologist. It is necessary to conduct a neurological examination at the outpatient state, which manifestation which will allow to identify patients. It's not severe lesions of the nervous system, but these patients lose their quality of life. They have a manifestation of depression, irritability, fatigue, and these patients complain the fact that their former performance is not restored. They require constant monitoring. What examinations are necessary for such patients, and is it possible to completely restore all functions of the central nervous system? Clinical study in Wuhan, China, based on 214 COVID-19 patients who underwent COVID-19. It was shown that 60% patients had some manifestation of nervous system damage. About 36% of patients showed neurological disorders, about 9% of peripheral nervous system disorders, and 1/4 of patients had central nervous system damage. 11% showed skeletal muscle damage. The main 2 symptoms that indicated damage to the central nervous system, headache and severe dizziness, which significantly worsened the quality of life of these patients. It required intervention in the treatment regimen for these patients. In our center, we are using Childer Fatigue Scale. The Childer Fatigue Scale is a questionnaire created by the research team of Trudy Childer at King's College London to measure the severity of tiredness in fatiguing illnesses. The fatigue scale has been used in multiple randomized trials of behavioral interventions in patients with mild encephalomyelitis, chronic fatigue syndrome. And normal range are 1 to 3 points. 4 and more is severe fatigue which needs help of psychotherapist. Associated kidney injury among hospitalized patients with COVID-19 in the United States has recently been reported to range from 28% to 46%. Early reports from China found the incidence of associated kidney injury to range widely from 0.5% to 29%. Proteinuria has in 40–50% of patients, and hematuria has been reported in 11% of patients. Associated kidney injury from COVID-19 is associated with poor outcomes and a high mortality rate. The mechanism of associated kidney injury in the setting of COVID-19 is unclear, but direct viral infection, cytokine-mediated injury, and ischemic injury have all been cited as potential positive factors. Can the kidneys recover from COVID infection? And what can be observed in renal function patients who have had mild COVID infection? It is interesting to know the pattern of liver injury in COVID-19. Hepatic involvement in COVID-19 could be related to the direct cytopathic effect of the virus and uncontrolled immune reaction, sepsis or drug-induced liver injury. Given the high expression of the ACE2 receptor in cholangiocytes, the liver is a potential target for SARS-CoV-2. Moreover, COVID-19 may cause worsening of underlying chronic liver disease, leading to hepatic decompensation and acute on chronic liver failure with high mortality. In many patients, we see an increase in ALT in the post-COVID period, which indicates persistent liver dysfunction. There is a bidirectional relationship between COVID-19 and diabetes. On the one hand, diabetes is associated with an increased risk of severe COVID-19. On the other hand, new onset diabetes and severe metabolic complications of pre-existing diabetes, including diabetic ketoacidosis and hyperosmolarity, for which exceptionally high doses of insulin are warranted, have been observed in patients with COVID-19. These manifestations of diabetes pose challenges in clinical management and suggest a complex pathophysiology of COVID-19 related diabetes. To address these issues, an international group of leading diabetes researchers participating in the COVID-GIAB project have established a global registry of patients with COVID-19 related diabetes. This is our case on COVID-19 associated diabetes mellitus. Patient male, 40 years old, worsening of the condition started from end of June of the current year with an increase in body temperature and appearance of weakness. Before hospitalization, he was ill for 9 days, received following medication, Theraflu and azithromycin. On this background, the patient has increased shortness of breath, weakness, oxygen saturation decreased to 92%. Due to the deterioration of the condition, on 8th of July, he was hospitalized. During observation, CT scan showed bilateral polysegmental pneumonia, examined by endocrinologist diagnosed with diabetes. You can see laboratory data of the patient on hospitalization and post-COVID period. Glucose level was high, as well as glucose hemoglobin. Vitamin D level was low. Fatigue is post-COVID period was assessed using the validated Children fatigue scale. Patient has 9 points. Also, patient started to have problems with hearing and vision. How does the human immune system react to the invasion of the SARS-CoV-2 virus? The host immune response to SARS-CoV-2 appears to play a critical role in disease pathogenesis and clinical manifestations. SARS-CoV-2 not only activates antiviral immune responses, but can also cause uncontrolled inflammatory responses, characterized by marked pro-inflammatory cytokine release. In patients with severe COVID-19, leading to lymphopenia, lymphocyte dysfunction, and granulocyte and monocyte abnormalities. These SARS-CoV-2 induced immune abnormalities may lead to infection by microorganism, septic shock, and severe multiply organ dysfunction. In patients with severe clinical manifestations of the disease and severe multiple organ failure, lymphopenia persists for a long time as a manifestation of insufficient immune control of opportunistic human infections such as CMV, Epstein-Barr, herpes, which can lead to their activation and the development of chronic inflammatory syndrome or other clinical manifestation of these infections. On this slide, you can see our case with patient COVID-19, patient associated with Epstein-Barr. Patient male, 50 years old, in anamnesis coronary heart disease and arterial hypertension. In June-July, he had COVID-19 bilateral polysegmental pneumonia. Post-COVID period, he has main complaints: memory loss, appearance of weakness, high arterial pressure, muscle pain, sweating. Childhood fatigue scale 11 points. Laboratory data shows very low level lymphocyte and big level immunoglobulin G, virus, capsid, antigen, Epstein-Barr. The big question: how to treat and help this patient regain working capacity and good quality of life? And next case, patient with COVID-19 associated with CMV in post-COVID period. Patient 43 years old, male, COVID-19 in June-July this year with high body temperature, appearances of weakness, headache. He was treated at home. Medical treatment was Theraflu, then Xarelta, then aspirin cardio. Now he has main complaints: appearance of weakness, problems with sleep, and the childhood fatigue scale 5 points. Laboratory data shows big level immunoglobulin G, CMV. And here is a big question too: how to treat and help this patient regain working capacity and good quality of life? We have started a project post-COVID syndrome about 2 months ago, and now we have 40 patients where 55% of them are male. Average patient's age about 50 years old. All patients has low level of vitamin D, and some patients has a high level immunoglobulin G, CMV, or herpes or Epstein-Barr, and some patients has high arterial hypertension, require an increase in the number and dose of antihypertensive drugs, and memory and sleep disorders. Childhood fatigue scale 6 to 11 points, and endothelial dysfunction. Examinations of patients include routine examination methods, cardiological and pulmonological examinations, determinations antibodies of SARS-CoV-2 coronavirus, D-dimer, determination of blood glucose and glucosademoglobin levels, assessment of endothelial dysfunction, childhood fatigue scale and consultations of psychotherapist, virus screening, examination of level of vitamins and microelements, and we suppose to examine for parasitic infections. What are new next steps? How to cure them? This slide shows the drugs that we recommended to our patients with post-COVID syndrome. Also, of course, breathing exercises, walks in the fresh air, psychotherapy sessions, and horse milk. What else can we do for our patient today? What are our next steps? How to cure them? Conduct the long-term study to assess the health status of the COVID-19 recovered patients. Follow-up survey of COVID-19 recovered patients will be helpful to evaluate any change in the other organs in human system. recommendations for COVID-19 recovered patients. And currently, a research project, Predictors of Prognosis and Long-Term Results of Post-COVID-19, is being discussed, which includes National Laboratory Astana Nazarbayev University, Clinics of Nazarbayev University Medical Center, the Academy of Preventive Medicine of Almaty, and our center. Who else will be included in this project, and with whom we will be able to exchange our experience and results? Thank you for attention.
I know that we have some questions to you, and I would like to ask the co-chair, Kliniska Ribayev, Dean of School of Public Health of our university, just to present the questions.
Спасибо, профессор. Спасибо, Лейла.
Thank you very much for your interesting presentation. We would like to ask you one question. Did you have analysis of venous deep vein analysis on thrombosis for these patients?
Can I speak Russian?
Yeah.
Ну, во-первых,
first of all, I would like to ask you regarding patients with COVID-19 or with post-COVID syndrome. Yes, these are patients with COVID-19. We've got this question from the audience. As a matter of fact, we are collecting statistics of samples we've got from 241 patients. This are preliminary statistics based on these data samples we collected from these patients post-intensive care units. And we do not know at the moment the exact number of patients with deep vein thrombosis, and the one serious patients on ECMO who unfortunately died. We also provided him ventilation, and when we made biopsy of his lungs post-mortem, we've got a lot of thrombosis in his arteries. No clots were found in his heart, but later on we will learn more about the status of these patients in terms of deep vein thrombosis. Thank you. So it turns out that we had echocardiography, and we did not do the ultrasonic examinations.
So we all know that the patients with some chronic diseases like cardiovascular diseases, endocrinological diseases, neurological diseases, they have a higher risk for more severe type of COVID-19 and maybe more lethal issues. So now with your presentation there is a question. Maybe you already know, maybe you could estimate how many of those patients who have a chronic disease and they faced with a COVID-19 infection, how many of them will have post-COVID-19 syndrome?
I do not have such statistics for the present time, because those patients who were dismissed, we followed up only those patients who lived in Astana, but we treated patients from all over this country. I would say that 30% of our patients suffered from hypertension, and about 70% had diabetes mellitus. These are most serious comorbidities which led to pneumonia. I don't know how many patients will return with post-COVID syndrome. We need to continue this project, which, by the way, was just started several weeks ago. We had only so far 40 patients who we randomly chosen. And after some agreements with and arrangements with the MOH, we will have a more closer look on these patients. Distinguished colleagues, I would like to start and present my slides in Russian. First of all, I would like to speak about the definition of primary health care in Kazakhstan, the so-called Soviet model of primary health care is represented by polyclinics, catchment area physicians, and tertiary specialists, as well as with family practitioners. The financing comes from various sources. For instance, the Family Health Center is financed on per capita basis based on the age and gender stratification. And for polyclinics, narrow specialists are financed based on their services provided per capita, per patient. In addition, we are focusing on transition to family medicine, and we train family practitioners. We currently have more than 7,000 FPs in PHC, and what is important to mention, we have 3 medical nurses. One is a visiting nurse, and in most instances such nurses are focusing on a special project focused on visiting services. You know that this project is for children under 5 years. Together with psychologists, they are coming, they are visiting families, households in order to detect problems with the health status and development of children under 5. Another important thing is that we have social workers in the team of medical practitioners, in the team of primary health care. These are social workers, one for 10,000 patients, but some hospitals decided that this is too big load for them, and they decreased the load down to 5,000 patients per one social worker. In addition, we have psychologists in this PHC team, and there is always a question what these social workers are doing. They are mainly focusing on diagnostics of the so-called social determinants and try to remove them. They are focusing on youth centers. We also have special centers for expectant women, and of course psychologists, they are focusing on mental health, suicides prevention, anti-depression interventions. In other words, a social worker focusing on social determinants, and they also can ask for assistance by the psychologists, and they are doing this. We're testing this system. In 2012, we replicate this experience all over the country. We're trying to expand this system to make it more integrated in terms of integration of medical and social services, to make it more resilient through establishment of various principles. Unfortunately, social psychologists' salaries are very low, and we try to improve the situation not only with the MOH but also with Parliament and the government. This was pre-COVID programs. We had also selection and training of patients with hypertension and diabetes. We try to teach them self-supporting principles and guidelines. Main thing is focused on calling ambulances for these patients, their hospitalization, and of course we try to raise their awareness on various complications of these diseases, and unfortunately during COVID these interventions were suspended, but now we try to talk over this issue with the social insurance system in order to make the social insurance system be more active and be focused on more on quality of their life, and most important is to make PHC oriented from patient-oriented system, which means that the Ministry of Health was rather interested in treating patients, ill patients, but rather to transfer to the so-called human-oriented system, which is more focused on prevention. There we try to determine principles of on how to prevent diseases, how to prevent mental issues such as depression. And for every category of patients, we developed our own guidelines. That means that overall PHC in Kazakhstan is not only about doctors and nurses, but rather be focused on patients themselves. These are only first steps in this direction. We are focusing on more steps towards decreasing burden on hospitals and to make primary health care more active and supportive. And here we have the whole system of rural health support. We have more than 40% of patients living in rural areas, and the same the same spectrum of services we would like to offer to our rural patients as well.
Due to shortage of time, and since this is a lecture and not a presentation, it's not a lecture but a presentation, I'd like to show how the PHC Association have responded to COVID and how it has worked together with the Ministry of Healthcare and the insurance foundation of our country. The first problem was that we had shortage of masks and individual protection, and during polyclinic phase during June and July there were only 30% masks for the doctors and nurses. It was very difficult because many people needed to be hospitalized. People were being ill at home, where people were dying at home. The ambulance were not arriving, so we needed to respond to all COVID challenges. So first we decided to create filters and triage systems to measure the temperature, but unfortunately they were not organized everywhere. Even in Astana, in the capital, 300 people were calling on the polyclinic, on the outpatient facility, and in the ambulance we were suggesting online consultations by dispatchers who would call to the ambulance. Probably you won't understand what it means, but in post-Soviet Union countries, our colleagues know that they would be turned to the consultant, and they would tell you that you are number 52 in the line. We can arrive after 5 hours, but I can connect you through to the consultant. And that's how, in one of the central hospital of Almaty region, we had almost up to 100% calls being cancelled, or the ambulance visits were cancelled thanks to consultations. In addition to that, call centers were organized for the people to call through the reception in the polyclinics. So we had a reception-free method where 80% patients have been scheduled for visiting their doctors using information systems. We decided to do away from the daycare because that would lead to mixing healthy and ill people. So we have organized daycare at home, which was serviced by mobile medical teams. That was proposed by our association and was supported by the Ministry of Healthcare. The mobile teams included, in addition to a doctor and a nurse, there were a social worker and a psychologist. So they were providing not only medical care but also psychological support as well. And based on the proposal of our association, 5 free drugs were included that should be available for a mobile ambulance team. And there were also a mobile medical team. There were problems with protocols. 12 of them had to be revisited, revised. So we are living in tune with all the changes happening throughout the world. The hospitals were buying in those drugs, but the problem was that in 2 weeks the protocol has been changing. Also, there were not enough beds in the acute care, and if this was not life-threatening disease, the patient had to be taken home in 2-3 days. So we decided to provide sister observation and care from one department to the other within the hospital, and then they would be transferred through primary health care. In the 27th and 28th, supported by the WHO and the WHO remote office, there will be a similar conference in Karaganda about the response to COVID-19. 8 countries are going to participate, and there will be the reports from the ministers, deputy ministers of health. The members of our association will come, so we will discuss the practical issues of how to live at this COVID and how to live after COVID, what will happen to those mobile teams in the peaceful time. For Kazakhstan, it's important to study the scientific foundation of 4 categories of triage. The 4th category have to be serviced by the polyclinic, by the outpatient facility. And it cannot be done by them only. So this issue is also related to PHC. The committees, together with the product of the World Bank and the Ministry of Healthcare in 17 regions or provinces, we're organizing public committees of the public trust to healthcare organizations. It's very interesting work when the communities are being organized in order to remove barriers for providing medical health care, in order to provide for access for all. So in one of our polyclinic, there was a line to the lab, so we had to have 10 people to go down and take the analysis, and in 15 minutes there were no line for the laboratory analysis. What kind of challenges are we to face? We hope that new protocols would be for daycare at home and for the daycare facilities. We are discussing this preliminary, and also we had to manage. There were not enough vehicles, so we had to give the government vehicles to every polyclinic. We were suggesting to have the sorting barracks near the polyclinic so that the ambulances could deliver patients fast enough. During the next wave, or if it will be a new infection, we need to protect our healthcare practitioners to make them healthy and operative. These are the kind of challenges that we are facing, and we are finding solutions. We have support of the business, such organizations as Dalastom and BPEC after. They were providing vehicles on their behalf or with their funding. There were also farmers and volunteers supporting us. So I believe that we have learned somehow the first war with COVID we have lost. We need to acknowledge that, and now we know where to proceed, how to proceed, and we need good treatment protocols in order not to lose our patients. Thank you for your attention. Thank you so much, Professor. Perhaps we have questions. Thank you for your presentation. There is one question from the web chat. You have listed a number of advantages of COVID developing online consultation systems, and at the last slide you were showing problems before the next wave of COVID-19. Do you think that PHC is ready for that second wave, and what kind of measures are we to focus? I've tried to answer that question. It's adequate funding for all the costs. The costs of purchasing individual protection means the costs for the surcharges for the healthcare practitioners, because now it was not paid to social workers and psychologists. Their salary was not raised. It was said that only healthcare professionals have to get increased pay. Now it's the cleaners in the hospitals that get more salary than the social workers and psychologists. So we have a lot of different proposals, and most important for the PHC is protection of our healthcare practitioners. Otherwise, we won't be able to provide any services whatsoever. Thank you for your attention, for your answer. And another question from me, if I may. The countries are facing such a challenge that the patients, the citizens, they are not enough trusting sanitary doctors as they trust the specialists. So they want to be directed to the specialists, to the pulmonologist, or how can we solve such problems, not to overburden the hospitals, but to provide services at home? I understand you correctly, and my opinion is that it's good to have national accreditation. Or accreditation for the quality, total quality, EUC, total quality management. To implement such system, it's quite important. But at the same time, it's important to have competence of every doctor. Yourself, myself, Cornish, the competence of how can we provide communicative skills and diagnostics. It's quite important for rural healthcare where there are no narrow specialists. And consultation of specialists at the polyclinical level, there are unnecessary visits. So we had experiments, and what happened? The number of adult neuropathologists has decreased twice, and the number of child neuropathologists have increased twice. And it shouldn't be. It's 90% of children have some kind of cerebral disorders, and for that there should be narrow specialists based only on indications, and these indications could be known by very skilled family doctors. That's why throughout this year, starting this year, we have 3-year residential program for the family doctors. And secondly, a surgeon, eye doctor, and the people who work only in the polyclinic, they become very illiterate. So they should be they should rotate with the hospitals in order to increase their skills. I believe that this will gradually come. So there are a lot of cases. We as experts of WHO have worked in Kyrgyzstan. We are also to cover Belarus and Uzbekistan. We are discussing with them. We have visited Turkmenistan. So we are to integrate medical and social care. That's our focus. And we believe that family doctors will be the pinnacle of the healthcare system, so that the patients will live active life and longevity in healthy state. That's our paradigm. Thank you so much for your answers, for your input and presentation. It's a challenge of post-Simashka system countries, and the primary health care are the most important, because we know that up to 80% they provide care at this level, and only 15% are provided at the next level. A little comment from me. Melitta Yakab with her team 2 weeks ago, the head of WHO remote office on primary health care, have visited a hospital in Kazakh district. So we should not only take the upper services of primary health care, but also it should be distributed among nurses and social workers, because social workers can do 40 to 60% of what the doctors and nurses do now. And now we have also nurses which could take up to 60% of functions that the doctors do now. So the doctor would be more focused on diagnosing diseases and providing the clubs, providing youth clubs, clubs for the aged people, elderly people, and clubs for pregnant women could be taken by other people. And the central district hospital of Yanbekshi Kazakh district will be the model polyclinic to become the best in the world. So you can congratulate us with that.
And now I would like to invite the speaker from United States of America, Professor David Bishai at the Johns Hopkins Bloomberg School of Public Health, together with Michael Schleif, an assistant scientist of Johns Hopkins Bloomberg School of Public Health. So, dear colleagues, the floor is yours. We are waiting for your presentation.
Thank you very much. It's good to be here. This is David Bishai speaking to you from Baltimore, Maryland, and Johns Hopkins University, where I'm a professor of public health. We're so glad to be here, and my colleague Micah Schleif will introduce herself as well.
Thank you, David. Greetings to you all. It's a great honor to participate in this important conference and conversation. I am Dr. Micah Schleif. I'm assistant scientist in the School of Public Health at Johns Hopkins, and have the honor to work with David and so many other colleagues to continue to move forward on this ongoing conversation and agenda around primary healthcare systems. So it's a pleasure to be here.
Great. So in the next few minutes, we'd like to share the work that we've done that was inspired by the 40th anniversary of the Alma-Ata Declaration. We both attended the Astana conference, and we're so excited that the idea of comprehensive primary health care is gaining so much more attention these days. And we would like to share in the next few minutes what we've done about that. We've written a book with several co-authors documenting how comprehensive primary health care has been implemented at the country level over the last 40 years. We believe these ideas are useful as we fight the coronavirus epidemic. And you'll see how the structures of primary health care have been used effectively to improve and achieve health for all. So in the next few minutes, we'll go over to remind everybody about the history of the movement for comprehensive primary health care, what happened back in Alma Ata, and how these ideas have been put into use since 1978. I'll turn over the slides to Micah, and she'll take us through the history. I'll show you how countries are applying these concepts, and then we'll close by showing us how the concepts are relevant to the COVID-19 pandemic.
Thank you, David. So this is just a quick overview of what David just covered of the three sort of topics, talking about the history and the origins of primary health care, looking at a country example from Nepal, and then wrapping it together sort of where we are now with COVID-19 and the Sustainable Development Goals. So next slide, please. And we do want to start off this conversation, as I'm sure you all have alluded to in this conference already, with the lead up to the Almaty Declaration. This photo here is from the conference in Almaty, Kazakhstan in 1978. And the conference certainly didn't come out of the blue. There had been, multiple decades of development work, including the whole efforts to eradicate malaria and mission hospital work, and just a very important, obviously much longer history than we have time to go into today. But coming out of that, by the late 1960s and early 1970s, was this realization that the work that had been going on, while certainly incredibly important and resulting in a lot of experience and evidence of, what was, where the challenges were in terms of reaching populations, working on sort of sustainable efforts to improve health outcomes, this realization that we needed to sort of take a pause and really look at what was working and what the goals should be, and which stakeholders needed to be involved, and a whole array of complex questions. And so in the early 1970s, there were actually two efforts to put together sets of case examples for what was working and how were development efforts around the world able to improve health outcomes, engage communities, and sort of really work on comprehensive development efforts that included health, but also really thought more broadly as a society and for communities as a whole, what was going to move the development agenda forward and be able to sustainably improve health across an array of different contexts around the world. So this was one of those two examples, a book edited by Dr. Kenneth Newell, who was working at the World Health Organization in the early 1970s, that, as you can see, pulled together a set of different case examples from around the world, showing how public health programs had also been integrated in different ways with broader health systems, with agriculture and education, and really kind of taking into account the needs of populations, engaging with communities, with governments in different ways. And so these case examples brought sort of inspiration and different models for how public health agendas could be moved forward in collaboration with different stakeholders in these various contexts. And so if we move to the next slide, this vision that was being built by the World Health Organization, by UNICEF, building on these case examples, really said, we recognize that there are inequalities, that we're not able to engage with communities to the extent that these different case examples have in different ways, and that those are some of the barriers that are resulting in not being able to achieve some ambitious health goals, being able to really improve public health delivery and broader community development. And so the Alma-Ata Declaration said we really recognize this, and we are coming together as a set of 135 countries to figure out how we move this agenda forward with an ultimate goal of achieving health for all by the year 2000. And so the declaration, which I'm sure you all have read, sort of lays that out as a vision, and with some principles and sort of an underlying philosophy based on those case examples. Next slide. And so what did the declaration achieve? So it certainly articulated this vision of primary healthcare in a way that hadn't been sort of conceptualized or solidified up until that time. And it really shifted from this sort of thinking about public health services just as, a set of things to do, but really as a process, as a way to bring together stakeholders, to address complex problems in holistic ways, and in order to commit to continuing this work of engaging communities and being able to sort of iteratively improve on these multiple different sectors and the many different people involved with improving and then sustaining improvements for public health outcomes as well as broader development. And it also achieved some consensus among these many different countries that attended the conference, as well as other really important stakeholders of the time, such as the Rockefeller Foundation and, of course, the WHO and UNICEF, that it was so important to focus on social determinants of health, multi-sectoral action, reaching populations that were underserved or marginalized in different ways. The challenge, however, was that there were not sort of a set of concrete targets for what does it mean if we're making progress towards primary health care or if we've achieved health for all. There wasn't a master plan for how to go about this, where countries should start, and there also wasn't a budget. There wasn't a plan for how we're going to pay for this work going forward. And so it did, however, leave these 7 principles, which are articulated in the declaration, and that are just a reminder as we have continued to work with the principles in the declaration that primary health care is a number of things that we consider sort of very solidly within the public health sort of profession and agenda, but it's also so much more. So recognizing, starting from point number 1 there, that achieving the vision of Alma-Ata will require social, cultural, and economic boundaries to be considered, but also that we really have to work across them, and that it requires sort of collaboration, problem solving, and sharing across different contexts, and recognizing that problems such as COVID-19 are spanning those boundaries, and being able to work together. Some of these next few, the 2 and 3 in particular, are sort of core public health functions, and just having the evidence and being able to mobilize and deliver appropriate services, but then also recognizing that health doesn't operate in a vacuum, certainly not at the community level, and so recognizing all of the other sectors that need to be involved. Number 5 is really critical. It's kind of the bedrock of Alma-Ata, and one of the things that came to the front in a way that it hadn't until the Alma-Ata Declaration, which is this principle of engaging with communities. And that means really listening to them, recognizing the resources that they have to offer, and then also giving them space within the agenda for both public health as well as their broader development for where do they want to go, what are the goals that they want to set. And the number 6 is really around equity and identifying that different subpopulations have different needs and being able to prioritize those that are most in need. And then finally, recognizing in principle number 7 that there are a number of key stakeholders involved in this work, and central to those in many of the models, both leading up to Alma-Ata and since then, are these auxiliary workers, which are commonly called community health workers, but there are many different variations on those titles, and there are also often at the community level other actors that play sort of bridging roles between communities and the public health system and other institutions that are operating at the local level. So these principles have were articulated in the declaration and have informed and sort of stood the test of time over the past 4 decades, and were also reaffirmed at the Astana Declaration in 2018. So this is a sort of visual way of remembering, as we think about public health programs, that we often end up sort of in number 2 and 3, maybe working on community health programs in number 7, but really trying to keep sort of that overall sense of the different pieces that have to come together for effective primary health care. Next slide, please. Great. So I'm going to turn back over to David here to talk through a couple of myths that we've sort of excavated as we worked on this book project, and in particular coming to myth number 3, and talking about how we go forward from here with the Alma-Ata Declaration, but also with all of the evidence and experience and sort of motivation that we have in today's complex public health world. So over to you, David.
Yes, thank you. I would love to be able to say that after the Alma-Ata Declaration, it was all smooth sailing and everybody gathered around to implement the plan. It was nuanced. There were many countries that did, which we'll be talking about, but many countries came under the myth that the real priority was economic growth, and there were decades of structural readjustment under the belief that a growing economy was the best way to make people healthy. The second myth, that if you were going to spend in the health sector, the main thing to spend money on was medical care and vertical programs like growth monitoring and vaccinations and promoting breastfeeding. These are good, but that was really the extent of international movements to improve health. And that was based on the idea that medical care was the main thing that was useful. The final myth that we'll spend the most time on is the idea that the Alma-Ata Declaration was completely impractical, a waste of time, simply beautiful words, but not something that could ever be achieved. And that myth, I think our book is going to do the most to show you a different way. First myth says that the only thing that matters is a growing economy. If the economy grows, everything is fine. Here is a growing economy. If you look at the horizontal axis, this is the United Kingdom, from 1800 on the left to 2010 on the right. This is the log of their gross domestic product. And as the GDP grows on the horizontal axis, we can see it doubling here. Every 0.5 is a doubling. And the life expectancy of the UK doesn't increase throughout the first 75 years of this graph. Between 1800 and 1875, life expectancy didn't grow despite the growing economy of the United Kingdom. They had doubling GDP, but the life expectancy was stagnant at around 40 years of life. The other thing you can see from this slide is about myth 2. Because life expectancy grew dramatically after 1875, all the way up, growing and growing. But the time that medical care becomes effective is 1950. So we have this tremendous increase in life expectancy prior to the realization of effective medical care. So effective medical care is not the only way to make health better. Certainly after 1950, the UK has benefited and the life expectancy is increasing because of effective medical care. But what we see in the early part of the graph is that the UK could make rapid health gains without medical care. So let me go on now to let Micah say more about myth 3.
Great, thank you, David. So what happened immediately after, within some months after the Alma-Ata Declaration, was that there were a number of concerns that were raised by different stakeholders that were committed to the vision, or were certainly critically thinking about what to do next, but raised some concerns. And so a number of these stakeholders came together in Bellagio in 1979 and said, we really need to think this through. How are we going to go forward? And the the concern really was that if you're going to do primary healthcare as articulated in the Alma-Ata Declaration, that means we have to do everything. And how, in particular, would Western donors, such as the Rockefeller Foundation, pay for all of these 7 principles and all of the things that were articulated in the Alma-Ata Declaration? And that raised a number of concerns. So what came out of that conference, and from there were a couple of sort of key articles, in particular this one from that time period, that basically said, the vision is great. We're not arguing that it's sort of the right thing to do. However, it is not practical. We can't do all of this at once. And so their sort of counter argument was, why don't we take a selective approach? Let's start with some sort of low-hanging fruit, some specific diseases that we know have solutions, and focus on those first, and sort of make progress and take care of those issues, and then be able to sort of branch out from there. And it was meant to be an interim strategy. However, it has continued to be sort of the status quo, or the way that a lot of different public health programs are rolled out, because it's a specific problem. You can set targets, you can show that you've made progress. And so, Welsh and Warren at the time were saying that, primary health care encompasses all of these different segments of the society, and that, it's just too much for any country to take on all of the things at the same time, which was not really what the writers of the Alma-Ata Declaration had in mind. However, when people were coming out of the conference and trying to figure out how to move forward, that just felt a bit overwhelming. And so if we go to the next slide, what has happened since then is that if you look at this graphic, you see sort of a total of the money that goes into health spending. And so on the left-hand side, you can see all of the money that goes into high-income countries, which is about $8 billion. And that's coming from governments and out-of-pocket payments and various sources. Then if you look at funds that are from within low and middle income countries that are coming from people paying for services and governments, you see that it's $833 billion, which is another significant amount of funding that's already within low and middle income countries. And then this final sort of pot at the top on the right-hand side of $46 billion, which is the international development assistance for health, which is still a significant amount of money in and of itself. But if you look sort of at the bigger picture, it becomes a fairly small proportion. However, those donors that have been contributing funds over the years that certainly have made a difference in terms of moving the public health agenda forward, were, however, a small sort of piece of the puzzle, and have been also dominating that agenda and sort of continuing this perspective from after the Alma-Ata Declaration of focusing on vertical programs, being able to show progress on specific fronts, and not sort of being able to make that shift towards how do we think about how all of the funds that are available for health are being used to their sort of maximum ability? Where are those funds coming from? How can we use them most effectively, and have sort of a broader strategy that gets closer towards the vision of primary healthcare and Alma-Ata. Next slide, please. Great. So this is our transition to look at how some countries that we describe further in the book as well have actually taken up the agenda for primary healthcare and that vision, and didn't get sort of stuck in that Walsh and Warren, we need to focus on these specific programs and be able to track these outcomes on low-hanging fruit, but have really taken that broader philosophy for how do we move development forward and ensure that communities are engaged, and that we create something that's really sustainable and moving us towards this vision of health for all. So David's going to walk us through an example of Nepal.
Yeah, and as we're saying here on the slide, the Western donors have project cycles where they have to do a thing and deliver something. But a country has to build a structure. It has to be a place that is able to cope with emerging problems like COVID-19. So let's look at the case of Nepal. Nepal is a country with a structure, a physical structure, topography that's quite challenging. It has vast areas of mountainous regions that are difficult to reach and to service a large rural population. Our co-author for this chapter was Dr. Rita Thapa and Dr. Kedar Baral, who Rita actually attended the Alma-Ata Declaration in 1978, and her perspective helped us see the long trajectory of Nepal in building primary health care. The history in Nepal was that during the 70s, they had typical project-based aid. They had a large malaria project that consumed half of their national budget, half of their budget on one disease, and really no emphasis on building primary health care. Well, in 1988, they did change course, and they built an integrated community health development program. This program was responsible for building a structure of village health workers and health posts that scaled up to cover all of Nepal. They kept on doing this despite a civil war. Even during Nepal's civil war from 94 to 2007, the village health workers kept on growing and expanding coverage during a period of civil war. And now we're in the point where Nepal's primary health care is consuming more than half, it's consuming 60% of their health budget. So let me tell you the structure that Nepal built during this period. They built a hub and spoke structure. They have communities that have a municipality with a health post. This would be serving about 20 to 30,000 people. And then sub-health posts, these triangles come off of the health post, where the sub-health post is the home base for a community health worker. These wards convene multiple sectors. Down in this triangle, there are a variety of sectors being brought together. So in the health post, there's a primary healthcare outreach center, a village development committee, and immunization outreach. Out here in these sub-health posts, there are village female health community volunteers making the rounds, but moreover, they are meeting everybody several times a month and going to water users groups, child clubs, cooperatives, mothers groups. They are bringing together all of society to talk about what can we do about our health. So that structure of having volunteers going door to door, as well as reaching out of the health sector, connecting the multiple sectors of society to say, what can we do about our health? How can we work together? This is the bedrock of primary health care. And this is the bedrock that Nepal is currently using to fight COVID-19. Female health community volunteers, the women you see here dressed in blue, there are now 50,000 of them in Nepal, one of these for every 560 people in Nepal. And there are outreach facilities for them to come from. And with Nepal having this resource, this army of health volunteers, and this network of health posts reaching out into their community, they've been able to use this resource in order to address the COVID-19 pandemic. So what's happening with this approach is the volunteers are having FaceTime. They're seeing everybody. This is so important for building trust, so important for building a real meaning of development. Development means becoming a place that can identify goals with all of civil society and can create solutions to new challenges. And COVID-19 is emblematic of complex challenges. It's a problem where we must build trust and we must build collective action. On the left-hand side of the slide, I wanted to highlight a diagram from the World Health Organization's operational framework for primary health care. This document is online at the WHO website, and it says that the three structures that we need to put primary health care in practice come from this blue wedge of multi-sectoral policy, which we saw happening in Nepal, this orange segment, which is empowering people and communities, asking them, what should we do together? Not just telling them what to do, but consulting them and giving them ownership and co-design privileges. And then finally, essential public health functions, primary care, having these structures that deliver public health services, the traditional public health services to solve health problems. The operational framework is a great blueprint for all of us in deciding how to go about doing this. I'll turn it back over to Micah to finish up.
Great, thank you, David. Next slide, please. Great, so I think very much aligned with the slide that you just saw with the WHO framework. These are three sort of assets that primary healthcare has built. We've seen across the 7 countries that are included in the book, and also just continue to come up as sort of critical themes within primary healthcare work, planning, implementation, evaluation. Just to reiterate quickly that this asset number 1 really is communities themselves. And focusing on, being in the community, ensuring that everyone in the community is reached and interacted with, and also consulted about their priorities. So I think that very much aligns with what David just covered. And then asset number 2 is this coordination with other sectors. We're seeing a lot more experience about ways to do that and really effectively engage with stakeholders at the national level, and also sort of cascading down from there to find the synergies and find sort of concrete ways of working together that can benefit multiple sectors, including public health. And then asset number 3, which aligns with that sort of delivery of health services, is to really promote and focus and support health equity and ensuring that underserved groups are receiving the services that they need, and being able to address some of the sort of underlying cultural and social dynamics that often sort of perpetuate and can even sort of exacerbate inequities that we're seeing around the world. And so these assets are things that are quite measurable, and have been able to show incredible progress across the countries throughout the book, and also have been integrated more into sort of the more recent primary healthcare frameworks, thinking about how to monitor and then really be able to sustain the progress that primary healthcare systems have built over the years, that events such as COVID-19 can often sort of put in jeopardy, and also at the same time can show just how important some of these structures are for public health. So in the final slide, we have just wanted to call everyone's attention to this book that just came out. We're incredibly excited about it, and there is a full text open access electronic version at the link that's right here under the book. So you can access all of the content that way. And we always welcome hearing from all of you if you have questions. We are excited to learn what the impact this book is having, questions that you have about it, and really be able to see how this agenda is moving forward with all of the work that all of you are involved with as well. So thank you so much.
Thank you very much, and thank you for a really very interesting presentation and approach to primary health care, and as well as the way of presentation by collaborating of 2 presenters, 2 speakers. It was really amazing to see. We have a few questions. First of them, you have emphasized that really more money does not mean more health, and you emphasized on primary health care as a possible solution for achieving better health. Could you please comment your point of view, those facts on really understanding what does it mean primary health care in low and middle income countries? Could you please describe it?
Yes, thank you for the question. So we've made the point that there's been this disconnect between more money spent in health and better health. I'd like to show a problem that we presented in this slide that emphasizes that point. We found in this era that the UK had trouble getting health to move when they were growing but not spending their money effectively on public health. When they spent money on public health, the UK was building this structure of home visitation and public health departments that changed the sanitation, the quality of the air. They did infectious disease control measures at the environmental area. These were the most effective interventions, and during this era, they were able to move their health statistics forward. We are finding now that we're hitting a ceiling, not just for countries that have high life expectancy. We're seeing this leveling off and this very slow growth of life expectancy, even in countries where life expectancy is low. Let me say that again. Because we're spending so much money on taking care of sick people and not on taking care of prevention in these public health structures, even countries with life expectancy at 60 and 65 are having a slowdown in the rate of progress. Waiting for people to get sick and then spending money on them is not the most effective way. The structures that we saw in our book, the first structure is having a municipality with health posts, having these health posts be the homes of health volunteers is so important to prevent. What's happening at these outlying areas is we have health workers going door to door, integrating with water and childcare and cooperatives and agriculture and schools, doing things before people get sick to maintain health. These are the interventions that Nepal is doing, and Nepal is leading the world at the pace of improvement of health. They are growing their life expectancy faster than any other country. And all the countries we see that do these interventions where we go out and spend on prevention with the structure of home visitation and essential public health functions can realize these rapid improvements. For COVID-19, this structure of having an army of people going door to door is so important in promoting the health behaviors that we need to fight COVID-19. Social distancing, masking, hand hygiene. Getting the message out and getting the trust comes from an army like this. And when we do have a vaccine, it will be an army like this that can spread the trust that's needed and help to fight vaccine hesitancy. If we don't trust the vaccine, we'll be in trouble.
Thank you, David. And I think just to add one, or really emphasize one point that you've mentioned, is that how important the relationships are, and building those relationships between communities, between local stakeholders, with national level planners, doesn't necessarily cost money, but it's certainly something to invest time in, and then resources have to be able to be reallocated to where they're going to make the most difference. But I think really emphasizing that sort of building of relationships in order to understand problems, trust each other, all of those things is something that's so incredibly important.
Thank you very much. And another question is also maybe a little bit provocative one. So even in high-income countries, there is strong shift from costly inpatient care to outpatient care, from outpatient care to primary health care. And you also have mentioned about cost efficiency. And as one myth, you have mentioned about high quality medical care. So could it be cheaper, but at the same time high quality medical care in primary health?
Thank you for the question. And I understand that medical care quality can fall down. There are many places where both private and public sector facilities are wasting money because the quality of the interventions is lacking. If you think about it, if you had to create better quality of medical care, you would create something that looked like a public health department. You would create something that was able to monitor the quality of the medical care out in every act of care. The thing you would create would look like what I'm calling comprehensive primary health care. The word comprehensive means it's operating with public health functions. It is one of the 10 essential public health functions to monitor and improve the quality of health care. So although I'm showing you a picture of the frontline worker of the community health volunteers, they are coming from a structure here. This orange circle is functioning as a local health department. If you have a public health department with a public health officer, that public health officer can be the steward of the quality of the medical care. So if we care about the quality of the medical care, we need to have public health officers with training in health administration, measuring quality, incentivizing improved quality, as well as doing environmental change, multi-sectoral collaborations. This is what's been missing. We're so focused on that final act of care of giving the medication to the sick person. And I am a doctor, and we focus on doctors only, but the doctors need some type of administrative structure to improve the quality. So I really think that if we are, and it's correct to focus on situations where the quality of medical services is lacking, but then the solution is not to put in more money into medical care. The solution is to put in more money into these oversight structures and to call them what they are. They are public health departments. And if we follow through with the WHO's operational framework for comprehensive primary health care, we automatically get governance of the quality of medical care.
And I would also say that I totally agree that so much of quality of care is really about cultural appropriateness, and back to that issue of trust and being able to get feedback from the community about, what are their concerns about quality of care, and being able to focus on, quote unquote, sort of the right things in terms of trying to improve quality. And so I think in addition to everything you said, David, that again, sort of relational piece and making sure that even if the scientific or sort of technical quality is good, that it's also reaching the communities as they will understand it and need it and be able to accept it.
Okay, thank you very much, dear colleagues, dear David, dear Mike. Thank you for the wonderful presentation and your answers to really good questions. So, and now I would like to ask for a last but not least speaker today, is Dr. Gregory Pappas, co-chair of the Pandemic Response and Emergency Preparedness Task Force from United States of America as well. Dear Gregory, the floor is yours. So, dear colleagues, due to technical problems, we do not have possibility to have our last presentation. Anyway, we will think that we will manage it to do somehow tomorrow. And I would like to thank you all of the speakers. I would like to thank you all of the participants of the second half of the conference today. And I would like to invite all of you to join us at 9 a.m. at Almaty time, and we will continue on the second day on our scientific and practical conference on primary health care and COVID-19 pandemic. So thank you very much for today, and hope to see all of you tomorrow. Bye-bye.